Hello and welcome everyone. Welcome. This is geriatric psychopharmacology. I'm Dr. Alessandra Strada and I'll be teaching this class, geriatric psychopharmacology today, and also chronic pain, psychopharmacology for patients with chronic pain. First of all, let me apologize to all of you for not being able to deliver this class live as we had planned. I know you're aware I had a family emergency, so I really appreciate your understanding. But I want to apologize because I recognize how disruptive changing schedules can be. I went through the program. I know how much sacrifice we put in and how much work we put in when we go through the program. So I really understand, and I'm sorry that disruption was created. I want to talk a little bit about the exam because I think that may be one of the concerns, and I'll do anything I can to make this as smooth as possible for all of you. So my exam will be pretty straightforward. I think this class is going to be pretty straightforward in terms of the content. And so I am absolutely positive that you all will do very well on the exam if you just listen to the class, the lectures, and really focus on the content of the slides. So pretty much all the topics covered in the exam are covered and mentioned on the slides, okay? I will also provide you with a fairly detailed study guide that will help you identify all of the topics that you need to focus on. And I will highlight important aspects of the class as we go through it today. So again, I really feel that you should not have any concerns. You will all do well if you listen to the class and look at the slides. Again, my questions will not be trick questions. This is adult education. I think my goal is really to convey and discuss with you a way of thinking about prescribing for older adults, and really being focused on some of how cautious we need to be, because this is a vulnerable population after all, and also I would say how important it is to, with older adults, with everybody, but with older adults in particular, it's so important to develop a patient-centered approach, which really means, not all 75-year-olds are the same. And certainly we know that guidelines have been developed and we want to follow them as far as prescribing goes, but we also need to look at the individual, what they can tolerate, what they're willing to tolerate, what their safety issues are, what the risk levels, what the level of functioning, and we'll talk more about that as we go through the class. So I hope that reassures, any anxiety related to the exam. I really think you all do well. And the goals of the lecture today are the following. So we're going to first talk about, and fairly extensively, about the challenges that we face providing psychopharmacological interventions to geriatric patients. And there are numerous challenges, and some of you may already be working with older patients, so you are aware about how careful we must be. We're going to present some of the principles of drug prescribing that are particularly relevant with this population. And then we're going to review some of the most common psychiatric disorders in late life, reviewing classes of psychotropic medications, indications, and contraindications. And we'll try to keep this as relevant as possible to the clinical setting, and especially to a setting that is integrated primary care. But you will notice that throughout the lecture, I will quite often reference working with patients with advanced disease, palliative care, because this is often, the working with older adults is really at the interface psycho-oncology, palliative care, even hospice care, because older adults may have several comorbidities in addition to mental health problems. So when we work with older adults, I think one of the main goals is really to optimize pharmacological interventions with every patient populations, of course, but this is particularly relevant to older adults because they are so vulnerable in many ways. So first of all, when we want to optimize treatment, we of course need to make a decision that a drug is indicated. We need to choose the most appropriate drug. We need to determine the dose and schedule, monitor effectiveness and toxicity, educate patients about side effects, and seek consultation if needed. So these are some of the main principles to optimize pharmacological interventions. There are challenges when working with older patients in terms of monitoring effectiveness and toxicity, because they may be less likely to report side effects. If we provide education, we need to make sure that the information is adequately received and integrated and processed, because that will increase treatment adherence, of course. And this could be sometimes complicated with older patients who may experience cognitive decline in some areas of functioning, but they may not be willing to discuss it or to report it for fear a stigma. But I'm finding that many older patients are really concerned about losing their independence. Older patients who live alone, they're afraid that if they mention any problems about not being able to remember their medication schedule, immediately the adult children or someone else will step in and say, well, you can't live alone. We need to move to Plan B, send you to a facility. And I'm finding that overall, this is a major concern, a major worry on the mind of older patients. And for that reason, it's sometimes difficult to really find out what's going on, and therefore developing a trusting relationship is critical, as we know. So let's talk about the specific challenges related to older adults. First of all, as you know, older adults are more susceptible to drug-induced adverse events. There are significant pharmacokinetic and pharmacodynamic changes as we age. Older adults often have concurrent illnesses. There's polypharmacy because they have multiple comorbidities, so they have to take several medications. Sometimes polypharmacy, as we will talk about, is really unnecessary. Sometimes, unfortunately, cannot be helped, because several conditions need to be treated at the same time. And there may be also poor treatment adherence for some of the reasons that I already mentioned, such as cognitive decline, unwillingness to report side effects, and then they may feel that the side effects are not manageable, they don't want to discuss it with their provider, and they will just stop taking the drug, or they will decide to take it at an intermittent schedule, which can be even more disruptive, as you know, not only in terms of drugs to treat medical conditions, but also medications to treat anxiety, or depression. So we know how difficult, how complicated it gets when patients take antidepressants on an intermittent schedule, and then they experience more side effect, and so it can really complicate and add burden to their symptoms. Patient-provider communication, again, is one of the main challenges that I think all of us working with older patients find. Older patients often feel disenfranchised. They may not feel that they can speak up. And I'm not just talking about the fear of being considered unable to manage themselves, but also their relationship with the provider may not be the warmest. So patients also know that providers are very busy. They have maybe 7-8 minutes for the encounter. They ask questions very quickly. One of the issues that comes up quite frequently is that patients complain that their provider, especially young providers or who are very, full of energy, they may speak very fast. They don't necessarily make eye contact because there's some of them staring at the screen, at the computer screen, because they have to fill out, the medical records during the encounter, which is unfortunately one of the aberrations of the modern technology. I mean, it's necessary, but it definitely creates a burden for patients and also providers. But many patients don't, they have a hearing problem that hasn't been really detected. So they may not hear, they nod, but they don't understand. So they nod and they want to show that they are in agreement, and then they leave the office and they have no idea really. Very little is going to be retained, and this is a problem. That unless a provider is really sensitive to these issues and they're used to working with older patients, they will not identify. So to summarize, older patients are less likely to discuss side effects, and they're also less likely to negotiate and challenge any treatment recommendations. So they're really less likely to participate actively in the management of their health. So let's briefly review some of the physiological changes in pharmacokinetics. In older adults, there's generally decreased hepatic clearance. There can be also decreased renal clearance of active metabolites. There are changes in rate of drug absorption at the level of the GI tract. And all of these changes mean that in many cases, there is a larger drug storage reservoir and decreased clearance, which then, of course, increases plasma drug concentration. And this is something to keep in mind. This is one of the reasons why in older patients it's exceptionally important to start slow and go slow. As we know, the effective doses in older patients may be 1/2 to 1/3 of the usual dose. If a side effect is dose dependent, we can consider multiple daily doses, but this may decrease treatment adherence. So there are several challenges. The risk of toxicity increases, and so it's very important to monitor very, very closely. Sometimes the side effects of toxicity can be minimized using small divided doses, as I mentioned, and titrating very slowly. But then again, the effect may not be what we were hoping for. Okay. Additional challenges are related to actually the use of herbal and dietary supplements. This is a really important topic, and I know that you have classes on this, so I won't go in too much detail, but it's very important that we obtain good information about what the patient is taking. There are some obvious drug-to-drug interactions, some interactions that are really well known. You're probably familiar with the fact that taking ginkgo and warfarin together increases the risk of bleeding. And actually, there are many older patients on warfarin, and they may actually take ginkgo because they want to improve their cognitive function. Taking St. John wort and SSRI can increase the risk of serotonin syndrome. And one of the issues that we may not be aware of is that many older patients actually take over-the-counter drugs, but herbal supplements. it's really the number of patients who are using this drug, these herbal supplements, has dramatically increased. And some of the most commonly used supplements include, as you probably know, fish oil, glucosamine or chondroitin, right, for joint problems, probiotics and prebiotics, melatonin, coenzyme Q10, especially patients with elevated lipid panels. They're told that statins deplete Q10, so sometimes they, actually many patients go to the store and they supplement with Q10, echinacea, cranberry, garlic, ginseng, ginkgo biloba. One of the problems that, first of all, these herbal supplements are not harmless. They have important effects. They have also important drug-to-drug interaction. They have important interactions with the drugs that the patient is already taking. Ginkgo and Chen John's wort, only some of the examples. But I think one of the main concerns is that there's really no regulation or very little regulation of these supplements. So in order to regulate this field, which is really kind of a wild land, there have been some bills passed by Congress, and there is the Dietary Supplement Health and Education Act that defines dietary supplements as a product containing one or more of the following: a vitamin, mineral, amino acid, herb, and other botanical, concentrate, metabolite, or extract. The labels of dietary supplements are required to state that this product is not intended to diagnose, treat, cure, or prevent any disease. However, as you're probably aware, product labels are allowed to make general health statements, general health claims such as this promotes prostate health, supports the circulatory system, supports memory, and so these general claims feel very attractive to the general population, especially we're talking about older adults. So they go to the store, they go to the grocery store, and they may buy something that is marketed, and not knowing how this is going to interact with the drugs that they're already, the medications that they're already taking. Unfortunately, the makers of herbal and dietary supplements are not required to prove efficacy, safety, or quality of the product prior to marketing. And amazingly enough, supplement manufacturers are also not obligated to report post-marketing adverse events to the FDA. And so it's really hard for patients to know whether the supplement that they're getting, first of all, if what is listed is actually what's inside the capsule, and also to make sure that there aren't any other contaminants, any other chemicals, solvents, and things that can be really dangerous to one's health. So quality is always an issue. For example, just if you talk about echinacea, there's different extract and different plants, different types of echinacea, echinacea purpurea, echinacea pallida, and or augustifolia. These are just 3 types, and they're all used sometimes interchangeably, so we don't really know the pharmacological effect of each of these extracts, and so often labels are misidentify the agent that is actually in the capsule. There's contamination by other parts of the plant or other plants. The harvesting and storage conditions may not be optimal and may allow for contamination. Processing sometimes involves the use of solvents like alcohol, glycerol, acetone, and so some of the solvents can be dangerous, can be toxic. Standardization is also a problem because there's no guarantee that The amount is actually in the capsule is standardized, so it's very difficult to evaluate what the effect can be. There have been reports of lead and mercury and arsenic contamination in imported traditional Chinese supplements and Indian herbal products. And sometimes it's even worse than that. Multiple brands, for example, of supplements that describe providing general adrenal support, adrenal health. We all have heard about adrenal, your adrenals are exhausted, so depleted and drained, so we need to provide adrenal support. Well, some supplements were found to have small amounts of thyroid hormone and at least one steroid hormone. Also, you know about the weight loss products that basically used ephedra with caffeine, and some of these products have been recalled because of the risk of hypertension, arrhythmias, myocardial infarction, stroke, and seizures. We know about the consumption of kratom, used for self-treatment of opioid withdrawal, has been on the FDA radar. There's been a warning because of risk of death. So older patients don't necessarily know this. If they have a provider who has a very judgmental attitude towards supplements and herbal supplements and otherwise, they are less likely to tell the provider what they're taking. Also, many consumers and older patients especially may feel that more is better, so they may tend to take more. So this is a problem that I just wanted to mention. One of the things that we can do is, first of all, obtain a very thorough list of everything the patient is taking. But also in terms of recommendation, because it's really hard to recommend a brand. But one of the things that can be done to inform the older patient who's a consumer of this supplement is to make him aware of anything that is really dangerous, that is evidence-based. The evidence has shown the presence of real danger, but also to encourage patients to perhaps prefer brands that have been tested by independent agencies, independent labs, for example, Consumer Lab, and to do a little bit of research. Nowadays, even the older patients are informed consumer. They are on the internet. They do research. They're part of chat rooms. So let's really honor their need to do what they need to do to improve their health, but also keeping them safe. And this is one of the challenges that that we find with the herbal and dietary supplements. It's a really big topic. As far as going back to some of the principles and the challenges in prescribing for older adults, it's very important that any new symptom, to keep in mind that any new symptom should be considered drug-related unless proven otherwise. Because if we don't do that, we may, the provider may prescribe an additional medication to treat an adverse event, and so this would cause additional problems. It's also this topic, the challenges are also so great because pre-marketing trials generally exclude geriatric patients. So if we're lucky, geriatric patients were included in some of the randomized control studies, but generally they're not really the focus of the research. And so this is a problem because we cannot really fully generalize the results of a study to what will happen to geriatric patients, which of course means they have to be monitored more closely. As we discussed earlier, drug dosage and volume distribution changes in older patients. Another example, the volume of distribution of diazepam is increased. Lithium clearance rate is reduced. So again, the risk for toxicity increases. Let's talk about polypharmacy for a moment, because polypharmacy is not ideal, is not a good situation. But simply, what does it mean? Polypharmacy is simply defined as the use of multiple medications by a patient. And so the precise minimum number used to define polypharmacy is variable, but generally ranges from 5 to 10. Polypharmacy really specifically and most commonly refers to prescribed medications, but as I mentioned earlier, it's very important to consider the number of all over-the-counter medications and herbal supplements used. Okay. The issue of polypharmacy is very concerning in older people because they tend to have more disease conditions for which therapies are prescribed. It has been estimated that 20% of Medicare patients have 5 or more chronic conditions, and 50% receive 5 or more medications. So sometimes this cannot be helped. The more drugs, the greater number of drug therapies have been independently associated with an increased risk for adverse drug events, for side effects, irrespective of age, and also an increased risk of hospital admission, decreased physical and cognitive capability, and as you know, risk of falls, and it's really a serious problem. Of course, we want to have a balanced approach to this. We cannot just underprescribe, just stop prescribing because of the risks. Because again, sometimes this cannot be helped, and it's necessary to keep the patient on a certain number of drugs. For example, let me give you just a quick example. A patient with a myocardial infarction, history of diabetes, elevated lipids will require a beta blocker, an ACE inhibitor, aspirin, statin, and a hypoglycemic medication. So many older adults do need to take at least 6 or more essential medications. And so we need to be aware of this. We cannot just focus on deprescribing. However, it's important to optimize the schedule, make sure that all the medication the patient is taking are really necessary. And one of the other aspects that is important, and I'm going to talk about that in this challenge, just want to mention it, and then we're going to go back. We need to define what the goals of care are. So as you see in the last point here of the slide, determine what the goals of care are. Are they curative versus palliative? Let me give you an example. In patients who are very ill, we need to improve quality of life, actively manage symptoms, but for example, if a patient has a life prognosis of a couple of months, it may not become as important, as critical to keep them on a statin drug, for example. In fact, studies have come out questioning the appropriateness of treating hyperlipidemia in patients who are very ill with a very limited life prognosis. So just to say that this is an issue of balance. We have 2 models that have been used and are currently used to determine risk, to evaluate risk, and these are important. And one is the drug burden index, and the other one is the Beers criteria. I think you should be familiar with both. The drug burden index really focuses on drugs with anticholinergic or sedative effects, the total number of medications and daily dosing, and really focusing on anticholinergic and sedating because they carry a lot of risks. For example, zolpidem, as you know, has been implicated in several emergency department visits for adverse drug events in patients 65 and older. So the drug burden index really looks at how many anticholinergic and sedative sedating drugs that is the patient on, because that really carries a lot of increased risk. The Beers criteria have been updated a number of times in 2012, 2015, and actually very recently this year, in 2018. And you're probably all familiar with this, but they really include, they discuss medications that should have been avoided, that should be avoided in older people, medications that are potentially inappropriate, and medications that should be used with caution. So it's not, they were developed as by an expert consensus panel initially in '91, and they targeted, this criteria targeted initially nursing home residents, but nowadays are really widely cited criteria to assess whether a drug is appropriate or not. Clearly, the Beers criteria are supported by evidence, but the American Geriatric Society advises that clinicians must consider many factors. So it's not about just removing the drugs and not using the drug. Remember what I said at the beginning of this lecture, not every older patient they're not all the same. Not every 75-year-old patient has the same risk factors. So even though a medication may be potentially inappropriate, but the patient is tolerating it well and they don't have significant risk factors, this is something the clinician needs to consider. And physicians do this all the time, of course, and when it comes to psychotropic medications, that's exactly where we come in, evaluating these principles in the context of, for example, treating late life depression or anxiety or minor depression or grief and bereavement, and we'll talk about it during the lecture. For example, the Beers criteria are very strict when it comes to avoiding antipsychotics for behavioral problems. As you know, the use of antipsychotics, especially in nursing homes, has been associated with an increased risk of mortality. So the guidelines or the recommendations are pretty strict, and the idea is that antipsychotics for behavioral problems should not be used with older patients unless all other options have failed and the older adult is threatening harm to self or others. Okay? So this is an important aspect to consider. Some other challenges, and we already touched on some of those, are anticholinergic activity, because we know that anticholinergic drugs carry significant risks, blurred vision, risk of falls, and we know all that. So we want to avoid as much as possible, and this is one of the reasons why, let me jump ahead, tricyclics are no longer recommended as the first or second line of treatment in late life depression, because the idea is to avoid anticholinergic activity as much as possible. However, in some cases, tricyclics may be the only medication that works for a patient, or they may be already on it, and they may be able to tolerate it well. So it really is an individual case. But in terms of the guidelines, anticholinergic drugs in older patients should be avoided. To summarize adverse drug events, we have prescribing cascade, where an adverse drug event is misinterpreted as a new medical condition. Now, for example, a medication that causes Parkinsonism, and then the Parkinsonian symptoms are misunderstood as actually Parkinson's disease, and the clinician prescribes an antipsychotic to control symptoms. This would be a typical example of a prescribing cascade. And drug-to-drug interactions. as I mentioned earlier, we have to put all this information together, look at the patient, look at what the patient's goals are, and determining goals of care. So are we curing a disease? Are these essential medications? Or are we just trying to provide a comfortable, as comfortable as possible, a situation for the entire, patient's life? And this is something that we will revisit when we talk about late life depression and depression in patients who are very ill, because of course you may already be aware of the fact that if the patient has only a prognosis of 2 months or less, and they are depressed, well, using an SSRI may just add to the overall symptom burden without really helping. The patient may not live long enough to begin experiencing the benefits. So we need to look at other options, and we'll talk about that. So what are to summarize, some of the practical suggestions with these populations where we talk about principles of drug prescribing? Maintain an accurate list of all medication, including herbal supplements and over-the-counter drugs. Periodic brown bag checkups. Making sure that the patient doesn't just give us a list, but actually they bring everything they take, because there may be a discrepancy between the list, may be outdated, maybe an adult child wrote the list, but it doesn't necessarily translate to what the patient is doing. And it's easier also for patients to remember, they associate it, they can be very tactile, but this is the bottle, the red bottle, and this is the bottle I take at noon. So let's make sure that we ask them to bring all the bottles, everything that they take, even things that they take once in a while. They may have decided to take Benadryl once in a while for sleep, which is a problematic drug to treat sleep disorders. So we need to be aware of that. Discuss potential drug confusion, drugs with similar names. Inform the patient of both generic and brand names. Encourage medication organizers. We also want to, I think a helpful strategy is to normalize any suggestion. So using medication organizers or writing down lists, a very precise list, is something that should be normalized. And the older patients should not feel that they're being targeted, that this information, this suggestion is being given to them just because they're older and we don't trust that they're going to be able to manage their medications. But we can just say this is what we recommend for everybody. Life is busy, everybody's busy. There are many things that you want to do with your life, and of course taking medication appropriately is one of those things that can really help maintain your health and allow you to do what you need to do in your life. And so we just recommend this to everybody, no matter what their age is, because we know that it can be time-consuming, and we certainly don't want to make mistakes, because then there could be, problems if you take medications incorrectly. So let's kind of normalize. It's not about your memory being bad, or it's not just about that. It's just about a very rational, understandable way, more really efficient way of organizing and taking medication. I'm suggesting this as a strategy, especially with older patients who are used to having everything under control, and they may feel a little offended, or they may just not volunteer that they're having problems taking their medications. Enrolling caregivers is always important, and this could be adult children, home health aides, but we also want to assess for caregiver burden related to medication. So let's not assume that an adult child is necessarily on top of everything, because especially if the primary caregiver is also very busy otherwise, and there are adult children who really try to manage to help their parents, but they can't do everything, or they get overburdened and then they forget, and then they don't say that they forgot. there can be very dicey situations. But I'm also thinking about another scenario where there is a patient, for example, who is ill, and the primary caregiver is a spouse, and the spouse, they may both be in their late 70s or early 80s, and some may be doing really absolutely well, and others, may have significant problems. So perhaps the husband, let's say, has several comorbidities and was just recently diagnosed with prostate cancer, for example. And the wife is the primary caregiver, but she may have a lot of chronic illnesses on her own, diabetes, COPD, heart failure. So let's not expect that the spouse, the caregiver, is necessarily going to be able to manage the challenges related to taking medications appropriately. Again, to summarize, always review current medications, discontinue unnecessary medications, consider adverse drug events for any new symptom, use non-pharmacological approaches as much as possible, depending on how the patient is able to engage and what is available in their community. Always consider safer alternatives, reduce the dose, and simplify the schedule as much as possible. Now, when working in a primary care setting with geriatric patients, there's generally a primary care geriatric workup that is recommended, and this includes a thorough medication history, an assessment of functional status, family history, and there are several laboratory tests that are routinely done to detect any abnormalities. Serologic tests, hematologic, the chemistry panels, thyroid, B12, folate, homocysteine, toxicology, urinalysis, and ECGs. And some imaging also may be recommended and may be done, but when patients describe cognitive declines, but there are some changes, like microinfarcts and changes in the brain that are really not detected by imaging. So the role of imaging is kind of questionable and may not necessarily offer good information that can actually be implemented in the treatment plan. Of course, it depends, but just to know that there are micro changes that are not necessarily picked up on a scan. And so the change that is seen on the scan may not necessarily justify or explain some of the changes in cognitive decline and behavioral changes that we may notice in the patient. So the areas for assessment as part of the workup include functional capacity, gait speed, and this, as we go through these, of course, you're thinking, anticholinergic drugs, very important sedating drugs. I mean, they're all really relevant to how the patient maintains functional capacity, gait speed, falls, risk of falls, what is their balance, how do they walk, and how is their cognition, presence of mood disorders, polypharmacy, and how is, not polypharmacy per se, but how is polypharmacy affecting, if it is, how is it affecting functional capacity, gait speed, risk for falls, balance, cognition, social and financial support, and also advanced care preferences, which is always a difficult conversation to have, but the literature is showing more and more that having these conversations when the patient is healthy and doing well, and there's no drama, there's not done in an emergency, is so much easier and can be done relatively quickly in the primary care setting. We as psychologists can certainly help have those conversations so that it's clear that we make sure that should anything happen like an emergency and the patient becomes incapacitated, that it is known what are their preferences in terms of what kind of care they would like to receive. So these are important conversations. It's better to do them as part of a routine conversation versus when there is an emergency and everybody is really upset. So assessing all these areas that we described is very important for both evaluation and management. The summary will describe all of the medical, psychosocial, and functional limitations of the patients, indications for referrals, and generally working with older adults in a primary care setting is done better as part of when there is an assessment team and where is a team approach that addresses all the different issues. And of course, in most cases, the team approach helps tremendously. If we're working as solo practitioners in a clinic or in an office and we see older patients, it's very important to have really good relationships with medical providers and, for example, case managers in the community, other clinics, so psychiatrists, other physicians who may be involved in the care of the patient. So really have a network of professionals that we can refer the patient to. Let's talk for a moment about functional status, because this is an important component of our assessment to determine how is the older patient functioning in their life, how are they managing what they need to manage, and also what's important to them. So there are basic activities of daily living, intermediate activities of daily living, and advanced activities of daily living. And the basics have to do with just the basic activities of grooming, self-care, maintaining continence. So just basic things that patients can do for themselves: self-grooming, self-care, continence. Now, intermediate activities of daily living have to do with the ability to maintain an independent household, take medications as prescribed. So this is not a basic activity, it's an intermediate activity of daily living. Managing finances, for example. So patients who are able to complete intermediate activities of daily living can be able to live on their own, and they manage their routines, they're safe. And now advanced activities of daily living involve the patient being able to fulfill various roles in the community. Perhaps they're working, perhaps they're volunteering, they're doing, they're babysitting for their adult children. They are involved, engaged in community organizations. But for a patient to be able to live alone and independently, it's just important to be able to manage finances and maintain an independent household, manage medications, very important. So this should be something that always comes into play when we assess an older adult. And so in the primary care setting, some of the most common chronic diseases in older adults that we see are, and the reasons why polypharmacy is also so common, are cardiovascular diseases, cerebrovascular disease, so balance disorders and falls, COPD, hypertension, hypercholesterolemia, thyroid disorders, type 2 diabetes, cataracts. This is an important one and not necessarily always detected early enough. The patient may have blurred vision. They think if they're glasses, they may just go to a store and get an eye exam, but of course just a vision test would not necessarily pick up on the cataract. So there are several reasons why something like a cataract, an undetected and untreated cataract, can really decrease the patient's quality of life and the patient's ability to function. Cancer, of course, osteoarthritis, because it's such it's a syndrome associated with so much pain, it can really become debilitating. various pain syndromes in older patients, GI disorders, osteoporosis, urinary tract disorders. Critical because they carry a really high risk of delirium that is generally quite undetected actually in primary care, and other geriatric syndromes such as dementia. And so those were the chronic diseases, the medical conditions. But we also see patients who are experiencing psychological and psychiatric conditions when we see them in primary care or in the hospital. Again, this applies to an integrated primary care setting, but also a hospital setting. In my experience, I've primarily worked in outpatient and inpatient settings, so seeing patients in the hospital and the clinic, and these are really conditions that we see across the board, across settings and across populations. Late life depression, confusion, anxiety, grief and bereavement, which is not a disorder, but it can become one, and we'll talk about it in a moment. Sleep disorders, very, very common in older patients. Cognitive impairment of any kind. Pain, fatigue, agitation, and delirium. Agitation can be part of delirium or just an anxiety state. Okay, so these are some of the most common psychological or psychiatric issues that come up for patients. And so what I would like to do next is to focus a little bit on grief and bereavement, because it is a common experience in older patients, and it can have significant consequences on their lives. So we're going to talk about that in a moment. Our next topic is grief and bereavement, and this is a topic that many people consider obvious. However, I find that is kind of a deceptive perception, because grief and bereavement, first of all, are very relevant to the adult population, but there are several clinical implications and also implications for psychopathology and mental health in general, in more general terms, that really need to be taken into account. So I thought it would be good for us to have a really brief review. Also, there are some changes, upcoming changes that are very relevant to clinical practice, such as the inclusion of prolonged grief disorder in the ICD, in the upcoming ICD-11. So I thought it would be relevant for us to talk about it a little bit. Many of you may be familiar with this. I'm just trying to kind of give you a brief review, and hopefully this will be relevant to your practice. When we talk about grief, grief is the general term used to describe a normal reaction to loss, any loss that's meaningful. And older patients experience numerous and ongoing losses. As their function decreases, they may lose their status, again, losing function, so losing that sense of health, becoming more frail. They lose friends. The older they become, the more lonely sometimes patients report, that the world is becoming, because many of their friends have died. And so there is a sense of loss that is persistent, ongoing, progressive. But in this particular context, we're going to talk about grief related to bereavement. And I wanted to clarify some of the terminology used in the literature, because sometimes the terminology is used interchangeably, and this can create confusion. So again, grief is the general term to refer to a loss, a significant loss. When we talk about the loss of a loved one, the death of a loved one, People can experience a variety of manifestations. There are physical, psychological, cognitive, spiritual, social. There can be significant physical distress, as you know, if you work with anybody who's lost a spouse or a child or a loved one. People can experience all sorts of symptoms. So grief is not a disease per se, of course. It's a normal reaction to loss. But the manifestations that people feel can feel very much like a sickness, because there may be anxiety attack, depressive symptoms, hopelessness, helplessness, even suicidal ideation. People who've lost a loved one may have also fleeting auditory hallucinations. It is not unusual for a spouse who's lost, for somebody who lost a spouse, to feel, to hear the voice of the loved ones. In my work with cancer patients, I've often found that, especially if the patient had poorly controlled pain and they used to complain a lot about pain and feel a lot of pain, and so they were really voicing complaints about pain. The pain was really bad. After their death, the loved one, the survivor, the surviving spouse, for example, may report that they still hear them lamenting and crying out in pain. So fleeting auditory hallucinations. On a cognitive level, we know that losing a loved one can trigger what may look like a cognitive decline, a sudden cognitive decline, decreased ability to concentrate, decreased ability to engage. People say, you know, I start reading a book, but I forget after half a page. I don't know what I'm reading. I cannot concentrate, losing things. Of course, when it comes to older patients, this is even more relevant because they may have additional problems managing medications. They forget. If they forget to take important medications, this is a significant problem. They may lose things, become more disoriented. So when we see patients, older patients, who are facing a grieving process, we need to be very attuned to what the issues are and really do a very thorough assessment. Bereavement, as you see in this slide, is one of the terms related to grief. Bereavement indicates what we just spoke about. So it's the state of losing a loved one to death. And so the state of having lost. It's not a process, even though in the literature sometimes when people write, they may say the bereavement process. But the psychological process of adjusting to the death of a loved one is really mourning, right? That's the psychological process. That's why some of the most important and relevant writers, clinicians actually, who have published in the area of grief and loss, like Teresa Rando, for example, don't really talk about complicated grief, but they talk about complicated mourning, because it is the psychological process of adjusting to the loss that can become complicated. And this is, you know, hence the difference between people who do hardcore research and people who work really clinically, because, you know, there's more of an understanding of what the psychological processes are. Grief from bereavement, grief from a significant loss is completely normal. It's a normal reaction. However, if grief cannot be managed, if the pain of grief cannot be managed, and this can sometimes happen not only in adult populations but in older patients who are particularly vulnerable, well, then the grieving process, the mourning process, can become complicated and it can become pathology. Now, over the years, there have been a lot of, several hundreds of studies published in the area of complicated grief to really alert and sensitize the medical and the mental health community to the fact that a complicated grieving process exists. It is substantially different from depression, so it's a different process. It's not major depression. It can, however, coexist with major depression, and bereavement, the pain of losing a loved one, can actually trigger a major depressive episode. So it gets a little bit more complex, right? Now, in the literature, those of you who are familiar with this literature, you know that many articles have spoken about, have described complicated grief as the pathological process of a grieving process. So basically, when the grieving process gets stuck and the patient, the bereaved individual, continues to experience severe ongoing grief symptoms without relief. Now, in normal grief, people can experience significant despair, even hopelessness, as I mentioned, even fleeting suicidal ideation. But what is the hallmark of grief, and we'll talk about it more in a moment, but what is the hallmark of grief versus depression is that in grief, the sadness and even the despair fluctuate. They're not all the time. They may be all the time for the first, maybe a few days and weeks, and depending on what the circumstances are. And of course, it's all very individual. There's no right or wrong way to grieve, because one of the things we've learned from research is that it is a highly individual process. So some people process grief more physically, psychologically. Other people are more cognitive and more focused on maintaining their routine. So there's so much variation, and also not to mention the cultural aspects. But in normal grief, going back to that, in normal grief, you will see that mood fluctuates. So the person can be doing really well during for a period of time, like the older patient, for example, who lost a spouse. Let me give you like a real life example that we often see in the clinical setting. Let's say a patient has lost a spouse, has lost his wife. Okay, his wife died, and they may still be able to engage with grandchildren. The children, grandchildren, visit grandpa. And he may still be able to engage with them and find pleasure, or a favorite grandson is graduating or granddaughter is graduating. They may be able to get the energy up enough to attend the graduation. And then they may return home and they may be absolutely exhausted, and then the thought that they couldn't share this event with their spouse may trigger crying, and may trigger a lot of sadness and missing the spouse. So there's a fluctuating ups and downs. So there are moments of despair and moments of ability to engage even in life-enhancing activities and connect with loved ones. So it's a process that continues to fluctuate, and slowly, even very slowly, but ever so slowly, most people with adequate social support and psychological support are able to continue functioning. And by that I mean they're able to integrate the loss of pain, integrate the reality of the loss, and they're able to, over time, invest energy, mental, spiritual, psychological energy in relationships with loved ones, with family. When the grieving process becomes stuck and becomes pathological, there's really no psychological, I would say, movement, and there's no fluctuation. So the individual, the patient, continues to experience tremendous sadness, despair, hopelessness, symptoms even of traumatic grief, and these are ongoing and relentless, and there's no improvement. And this is when we talk about pathology. This is when we talk about complicated grief, also known as prolonged grief disorder. Now, why these two terminologies? I'm just going into this briefly because you may know about this, but just to give you a context. Over the years, two main research groups have studied grief, complicated grief reactions, let's say. One was the lead author, wonderful researcher and clinician, Catherine Shear at Columbia, in New York City who really developed criteria for complicated grief. She called it complicated grief, and also developed a clinical application. It's probably the only, one of the few, probably the only, I would say, evidence-based psychological treatment for complicated grief that we know, that's been studied over time, and it's complicated grief therapy, which is therapeutic work really focused on that there is a narrative component, a trauma component, exposure is a component of this therapy. It's a time-limited approach, kind of manualized, but really addresses all the different components of complicated grief. But at the same time, another research group led by Holly Prigerson at Harvard developed prolonged grief disorder as a descriptor, as a diagnostic entity, actually, that described a complicated grieving process, pathological grieving process. So these two entities are substantially very similar, just some changes in criteria, differences in criteria, but they're really very similar. Both were proposed for inclusion in the DSM-5. And you may know this, and so complicated grief and prolonged grief disorder. And basically the rationale was, well, a pathological grieving process is real, is different from depression, as several studies have demonstrated, and this is the general understanding in the literature. So it does exist. It's very substantially different from depression. So it's a different disorder, and it should be included in the DSM because it causes severe impairment in the patient's level of functioning, and this has serious implications, and it should be treated. Now, after evaluating all the evidence, the DSM-5 task force decided that there wasn't enough evidence to include complicated grief or prolonged grief disorder as a separate diagnostic entity. So what they did, they included a disorder that has a completely different name, called persistent complex bereavement disorder, but it's only included as a diagnosis for further study. So the criteria are listed, but the DSM clearly says they should not be used clinically. This is only at a research level, and of course we're talking about 2013 when the DSM-5 was first published. And there's been a lot of research after that. I would say that persistent complex bereavement disorder is really rarely used. I mean, people are not really diagnosed with that because if it's a research diagnosis, you know, it really has little relevance to the clinical setting, and most clinicians are actually familiar with the term complicated grief or prolonged grief disorder. So that was the result of the attempt to include these two diagnostic entities. So that didn't work. But there was another very important change in the DSM-5 that is related to grief, and this is really relevant. It's the elimination of a bereavement exclusion criterion in the diagnosis of major depression. What that means, as you know, is that an individual who was recently bereaved can be diagnosed, can receive a diagnosis of major depression. So the second point on the slide, the elimination of the bereavement exclusion criterion in the diagnosis of major depression, has created a lot of concern in clinicians who are afraid that this will result in being in an overdiagnosis of depression. And overall, I think the main focus of concern is the fear of medicalizing grief, the fear that patients will be prescribed antidepressants, And of course, this is a very important and a very relevant change in the DSM. But I think in my clinical experience, there are several factors that need to be taken into account. First, bereaved caregivers, let's say the spouse, the man who's lost his wife, or vice versa, they may actually have developed depression before the death of the loved one. And just the tasks of caregiving, caregiver burden, there may be a variety of reasons why they may have already developed depression, which was, however, undetected, undiagnosed, and untreated because the focus was on the patient. And so we know caregivers don't really want to distract the attention from the patient, or they may be concerned that if they say I'm depressed, somebody may come in and may say, well, you're not able to take care of your wife, we cannot keep her at home. There's so many issues, and when people are older, they are more concerned about this. Like maintaining their independence at home is paramount, and so they'll do whatever they feel they have to do to maintain that sense of independence. So if one has been depressed already for a period of time and then their spouse dies, there's no reason why they should not be, this depression should not be recognized, right? We don't want to trivialize or normalize depression just because we're afraid that we're going to medicalize grief. The second point is that depression and grief in bereavement can coexist, of course. People can be grieving and they can be depressed. It's important to address both. Grief needs to be supported. It's not a disease. It doesn't need to be treated, but major depression is. And the third point is that really this speaks to the importance of training primary care providers and for us as psychologists to develop the expertise that will allow us to differentiate between what is depression and what is a grieving process, so that we would not over-pathologize what is a normal process that just needs to be supported and monitored. But we also will not trivialize or normalize or provide non-specific support for major depression, which needs to be treated in a very different manner. The reality is that many, over 50% of people who've lost a spouse develop major depression in the first year after of bereavement. So it is a real concern. So in the DSM-5, these are the two main changes. I would like to now open a small parenthesis on anticipatory grief. If you're working with older patients who are very ill and they're approaching end of life, you may notice that they may appear depressed, but upon further assessment, you may notice that they're really experiencing a grieving process that is related to their failing health, worsening disease, and the fact that they are approaching end of life. Many patients who are aware or want to connect with the awareness, because some people may decide not to think about it until the very end, and again, it's exquisitely individual. But in patients who are aware of what is happening, this may trigger a profound grieving process that's been called preparatory grief. Kubler-Ross actually first spoke about this, and I think it's interesting that her description has been often misconstrued and applied to every grieving process, when in fact her studies really focused on terminally ill patients who were talking about their sadness and their grief as they were approaching end of life. A grieving process in someone who's approaching end of life is certainly not pathology. It's often different from depression, but it could be comorbid. They could be both. And again, anticipatory grief, when it's a grieving process and major depression is not involved, mood generally fluctuates and there's a general lack of worthlessness or irrational guilt. And Caregivers, family caregivers can also experience a significant grieving process. For some of them, it could be actually worse than bereavement because it really triggers tremendous grief manifestations and anxiety. It requires ongoing monitoring. It's very important if you work with a spouse or with a caregiver who is grieving and is an older, let's say you're working with a spouse who's a primary caretaker for their own spouse, working with a patient who's caretaking for their spouse. We should definitely monitor their own grieving process, identify concerning behaviors. We want to respect cultural expressions of grief, but we also want to monitor possible risk factors for complicated grief reactions. Concerning behaviors may be those of, the caretaker stops taking medication. They generally stop implementing self-care practices that are necessary for them to maintain their independence and maintain their health. So this would be a very concerning behavior, and it's important that we provide the support without undermining their goals. And just to summarize, these are just some of the main differences on a clinical level. If we look at how grief and depression present clinically, preparatory grief, you can think about preparatory grief, but also grief in bereavement after the loss of a loved one. So in a normal, what we call normal, even though it doesn't feel normal, and I'd like to emphasize that, in a normal grieving process, mood fluctuates, whereas in depression, the patient feels sad or low most of the time. In grief, self-esteem is generally intact. They're very sad about losing the loved one, and there may be some guilt about, well, I should have taken him to the doctor sooner. I should have forced him to go to the doctor, or I should have stopped him smoking, years ago, or I should have gotten that screening. There can be some guilt, and some of that may be based on actual events and things that actually happen, but that generally does not undermine the entire sense of self-esteem. So self-esteem, the core of self-esteem, is generally intact, whereas in depression, the patient feels feelings of guilt, irrational guilt, and worthlessness most of the time. So the sense of worthlessness, of not even deserving the help or the care. In grief, as we mentioned earlier, the patient is able to enjoy seeing and interacting with friends and family. When I say enjoy, I don't mean they're going to jump and be, elated or anything like that, but they're able to connect. You get a sense that even though through their sadness and tears, they connect with friends and family. They have moments where they welcome the support and they're able to respond to the support. Whereas in depression, there's a general withdrawal from friends and family and anybody who wants to provide help. In grief, there's still the possibility, the small pockets of pleasure, that can be experienced, like I mentioned earlier, attending a grandson's graduation or a granddaughter's wedding, and the sadness is mostly related to the fact that, oh, my spouse, couldn't see this, grandma couldn't see this, she would have loved to see it. In depression, the patient is less talkative, is not engaging, there's anhedonia across the board, inability to make decisions, kind of a frozen state. In preparatory grief, like I said, there's still some ability to look forward to special occasions. Of course, this doesn't mean that special occasions will not be followed by significant sadness and grief, and mostly really a sense of depletion and exhaustion, which patients can feel when they're grieving, because grieving, just managing the pain of grief, takes a lot of energy and takes a long time. But let's talk for a moment now about the complications of grief. And these occur, and we just mentioned them. One is major depression, anxiety disorders, and complicated grief. Now, complicated grief reactions, from now on, I'll refer to them as complicated grief and prolonged grief disorder, okay? Because prolonged grief disorder will be included in the ICD-11. What does the clinical experience and literature tell us? Well, it provides some support for the use of antidepressants. So, for example, in depression, the use of antidepressants in bereavement-related depression, which is depression that is triggered by the death of a loved one, can be appropriate to relieve depression symptoms, and may also be safe. The literature, the studies are showing that they're relatively safe, and they're also moderately effective. We have limited data, but the data that are available to us indicate that they're safe and moderately effective for the relief of the improvement of depressive symptoms. So, so there's some support for the use of antidepressants. Combined therapy often provides the best results, as in the case of grief, because interestingly, antidepressants do not relieve grief symptoms, but they relieve the depression symptoms. So grief therapy, if the patient feels that they need that or they can maybe benefiting from that, should be definitely offered. Now, this last point here is very important. The concern that medication interferes with the mourning process is not supported by evidence. So in the literature, you know, there's been a lot of ongoing conversation about, well, if we medicalize grief, if we give antidepressants as somebody is grieving, we'll interfere with their grieving process, and we'll just stop the grieving process, and then they will have to deal with it years later. There's really, and I'm saying this from reviewing the literature, but also working with bereaved individuals regularly. This is part of my expertise, working in psycho-oncology with children and adults and older patients, and also palliative care. And so what we see in clinical practice is that this is really not accurate. Antidepressants do not really interfere with the normal mourning process, but they may relieve if there is coexisting depression. And relieving the depression may be important not only for safety, because people can become suicidal and can actually go ahead and attempt suicide if they're depressed and there's hopelessness and helplessness. But they will continue to grieve. Grief doesn't go away. So this concern based on anecdotal evidence or just the idea that antidepressants are always bad, of course we don't subscribe to that kind of bias, but it's important to also reassure patients. You know, sometimes it is necessary to provide both a pharmacological and a psychotherapeutic approach. So to summarize, in bereavement-related depression, we don't have a lot of studies. I just wanted to highlight some of the early studies on desipramine or nortriptyline, which of course would never be the first line or second line of treatment in late life depression, and not the main line of treatment, the first line of treatment, not only in older adults but also in younger adults. So you see studies from the 80s, the early 90s, case studies, because this was really the beginning of this work. And so much research has been developed since then. So the field has really expanded tremendously. So tricyclics have been studies, bupropion also. the impact of antidepressants and activities of daily living in older patients. There was one case study about the use of sertraline for disturbing dreams related to the death of the loved one, and where sertraline was well tolerated and improved symptoms, and also the use of antidepressants in patients who were depressed post-bereavement. In older patients, this is important, really allowed them to continue to perform activities of daily living. And since then, we've had several studies that have just looked at patients who are already on antidepressants, and Catherine Shear and others who's, as I mentioned earlier, developed complicated grief therapy. Many of the studies that have come out of that research group, and very recently also, have looked at how the presence of antidepressants helped or somehow compromise the patient's ability to engage in therapy, in psychotherapy. And actually what they found is that relieving depression can actually be beneficial to allow the patient to engage in therapy, because the therapy for complicated grief is engaging. There is an exposure component, which is difficult, a narrative component, kind of a gestalt component. So it's a very active form of treatment, of psychological treatment. So we certainly want to make sure that the patient is able to engage. And coexisting medication has not interfered with the patient's ability to complete psychotherapeutic work. Prolonged grief disorder, it's what we're talking about. It's, to summarize, there is a state where the bereaved individual is kind of symbolically frozen or stuck in a chronic and constant state of mourning. There is psychological protest against the reality of the loss. What I wanted to, again, remind you of is that the prolonged grief disorder will be included in the ICD-11. So it won't be complicated grief, but it's called prolonged grief disorder, developed by a different research group, criteria very similar. The symptoms must have been experienced for at least 6 months. You need to always consider cultural differences, because in some cultures, of course, you would not even contemplate engaging in normal behavior for at least a year. So we want to be very mindful of that, because we certainly do not want to over-pathologize. But I wanted to, and I'm not asking you, you will not be tested on the criteria. I just want to briefly mention them as you're listening to the lecture. So the ICD-11, the prolonged grief disorder criteria, will have at least one of these two symptoms, either persistent and pervasive longing for the deceased, or a persistent and pervasive preoccupation with the deceased. And of course, people who lose a loved one are always longing. So one of the objections, you're always long for the person who died, and you have some degree of preoccupation. The difference is persistent and pervasive, and that's really the hallmark. When something is persistent and pervasive, excuse me, there's really no room for anything else. No room for self-care, no room for life-enhancing activities, no room for returning to some level of function or continuing on with life. And you'll notice that I didn't say moving on. First of all, I don't like that expression, but people don't really move on. People learn to exist in a world without the loved one, right? So it's a kind of relearning and reinventing that. And then, so either the persistent longing or preoccupation. That is also then criterion B, accompanied by intense emotional pain, such as sadness, guilt, anger, denial, blame. There's difficulty accepting the death, feeling that one has lost a part of oneself, emotional numbness. And this continues for over 6 months, or for an unusual period of time, considering the cultural context, what is culturally normative for the patient. So again, when someone is experiencing prolonged grief disorder, antidepressants do not interfere. They may actually help because there are depressive symptoms that can be relieved. And in depression, in bereavement-related depression, the use of antidepressants can actually be considered and may be considered because they can be appropriate to relieve depressive symptoms, and they may be safe and moderately effective. Again, this summarizes the pharmacological management for prolonged grief disorder. Depressive symptoms improve earlier. Other medications that I've been studying early on, paroxetine and therapy for traumatic grief, escitalopram, which has been a very small case study. But again, like I mentioned earlier, most of the studies from 2008 and current studies have really focused on the concurrent naturalistic pharmacotherapy and complicated grief therapy. So you'll find a lot of information on that, and this is why we can say quite, comfortably that the presence of antidepressants does not interfere with the normal grieving process, and in complicated grief, they may actually be necessary to allow the patient to engage in treatment. Now, what I want to just talk about for a moment is a concerning practice that we still see, and this is the use of benzodiazepine in acute grief. This is very concerning with older adults. It is concerning across the board. Let me give you this scenario. Again, we have, let's say, a 70-year-old woman who sees a primary care doctor. Her husband died very recently, and she tells the doctor, I can't sleep, I'm exhausted all the time. I'm unable to sleep. I just don't get any rest. I cry. I'm anxious. I have these panic attacks, anxiety attacks, and often what some primary care providers do is to provide, hopefully a short-acting if they really have to, but a benzodiazepine for sleep and anxiety. Now, this is concerning because of all the risk factors, all the risk of falls and dependence and toxicity and confusion in older adults, but also because in some studies have indicated that people who were prescribed benzodiazepines immediately after bereavement were still on the same benzodiazepine years later. So, for example, they received it because it was supposed to help them sleep in the first week because they were so distraught. And then somebody, the physician, continued to fill the prescription because at that point the patient had become dependent. They would say, listen, I can't sleep without this. And of course, many adverse drug events related to that, to those prescribing practices. So this is something that should be avoided. In many cases, when somebody cannot sleep at night, in the aftermath of bereavement, of course, nobody can sleep. But generally, in many cases, people then catch up. They may be up all night, and then, let's say 4 o'clock in the afternoon, they may just crash and say, "Gosh, I need to go take a nap because I'm exhausted," and so they kind of catch up slowly. They may still be sleep deprived for a while, for a few days, but then they may be able to sleep a few hours every night. So the pattern may kind of become a little bit more normal. Now, I need to say that if sleep is persistently disrupted and the individual is so aroused, the level of arousal is so high, and they're so anxious that they cannot get any sleep, and they're like totally, completely wound up and highly, highly anxious and they do not get any sleep, not even naps, so there's no way of catching up. This is, of course, very disruptive and risky. So there is a role for the short-term, the judicious short-term use of perhaps benzodiazepines, but if we're looking at the importance of sleeping, perhaps a non-benzodiazepine, we will talk about that later, would be more appropriate. If a benzodiazepine is considered, it should be really only short-term, and the primary care provider, the provider should monitor very, very closely and make sure that other strategies are implemented, whether it's sleep hygiene or teaching self-hypnosis. Again, this is one of the situations where a lot can be accomplished by using non-pharmacological strategies. And because I use clinical hypnosis very frequently in a variety of settings with different patient populations, I found that this is some of the things that can be taught. Patients can learn to self-soothe and just improve the likelihood that they will fall asleep, and then over time things should improve unless we get a sense that then there's complicated grief and then we have to treat in a different manner. But I would seriously caution anyone against the use of benzodiazepines right after bereavement. And if it has to be done, again, consider all the risk factors, monitor very closely, and only short term. If there is anxiety, persistent anxiety after bereavement, the standard of care, the first line of treatment would be an antidepressant, not a benzodiazepine. So for you, this is just basically to summarize the questions. When are benzodiazepines and hypnotics appropriate? When are antidepressants appropriate? Benzodiazepines and hypnotics, short-term, mostly for crisis intervention. Antidepressants can be and are appropriate when treating bereavement-related depression, and they can have a role in complicated grief. Let's now talk about late life depression. So first of all, let's talk about the terminology. What do we mean by late life depression? Well, this includes both patients who are aging, who had depressive disorders that presented earlier in life, and also patients whose depression presents for the first time in later life. So late life depression really refers to both, okay? Patients who had it before, and patients who develop it for the first time in late life. We know that late life depression is really underdiagnosed and undertreated. It's inadequately treated. In the United States, you probably are aware of all this, older men and older African Americans and Hispanic patients are even at greater risk of unrecognized depression. Over 80% of mental health treatment for depressed older patients is delivered in the primary care setting. So for those of us who work in integrated primary care, it's also those of us who work in private practice, it's so important to develop a very close relationship with the primary care providers, because some of them are very well trained, some of them are not, and there's still several misconceptions and barriers to the diagnosis and treatment of depression. It is not a normal consequence of aging, and it's not even a normal consequence of advanced illness, and this is important to remember. It's not a normal consequence of advanced illness. Even patients with advanced cancer or patients at the end of life do not necessarily develop depression. So it's not an expected consequence, and when it does occur, it creates tremendous distress, and it really should be treated, should be actively treated. It can be triggered by bereavement. So that's something, as we mentioned, something to keep in mind. And again, as we mentioned earlier, older patients have experienced a series of losses and progressive losses. These losses do not necessarily and automatically trigger depression. We can certainly say that rates of depression are higher for older adults who are also medically ill, and older adults in the general medical setting. The research shows that hospitalized patients, hospitalized geriatric patients, have prevalences of depression over 30%. And patients, especially with stroke and myocardial infarction or cancer, have rates over 40%. And as you know, depression is particularly common. There's a higher association with some cancers, such as pancreatic cancer, for example. Different explanatory models and hypotheses for that. It could be because patients are generally diagnosed very late in the course of illness, so their life expectancy is generally poor, or this may be related to inflammatory cytokines that are released and may be responsible for the depressive symptoms. But the reality is that in patients who are also medically ill, depression is highly comorbid. So some of the risk factors that we need to consider are kind of the same across ages. So female gender, there is a higher prevalence of depression in older women. And this could be because there's greater susceptibility to depression, greater persistence of depression after its onset, a lower mortality. Men, for example, older men who are depressed are more likely to present with anger, irritability, anhedonia, withdrawal, or apathy, and they may present more with alcohol abuse. They're less likely, as we know, to acknowledge sadness or psychological symptoms. So this may be one of the issues. Social isolation, uncontrolled pain, this is a really significant one. In fact, in the presence of uncontrolled pain, patients may exhibit severe anxiety, depression, hopelessness, suicidality. So it's very important that whatever can be controlled medically, reversed or controlled, be addressed before we offer a diagnosis of major depression. So basically diagnosing an older patient, and actually also a younger patient, but we're talking about older patients here, diagnosing an older patient with major depression or an anxiety disorder in the presence, in the context of uncontrolled pain would not be appropriate. So we need to make sure that everything in the physical symptoms are somewhat controlled so that we can do a more thorough assessment and deliver a more accurate diagnosis. Other risk factors: cognitive impairment, insomnia, definitely sleep disorders are a significant risk factor for depression. Low ACS, comorbid medical illnesses, as we said, and also depression can be precipitated by life events such as being widowed or a divorce. Being a nursing home resident is a major risk factor. In fact, studies have shown that as many as 50% of nursing home residents are depressed. So for a variety of reasons, there may be a sense of abandonment, the care may not be up to the standards, there may be no attention to, some facilities pay no attention whatsoever to mental illness, or mental health. Patients are not engaged. In some urban areas, it's really very challenging, few resources. We know all that. Depression is a major risk factor for suicide in older patients. Suicides in older patients accounted for 13% of the United States population, but for nearly 24% of all completed suicides. As we know, older patients attempt suicide less often than younger people, but they are more successful at completion. Older men have the highest suicide rate, and especially, as you probably already know, white men age 85 or older have the highest rate of completed suicide. And the sad thing, and kind of terrifying in many ways, is that most older patients who completed suicide were in their first episode of depression and had seen a physician within the last month of life. And this is heartbreaking, terrifying, very concerning. It really speaks to the importance of doing a thorough assessment, but also the importance of not trivializing. Like I said earlier, you know, in bereavement, we can't just say, well, of course he's depressed because his wife died. He's very depressed, but he'll get better. Well, he may not. If there is coexistent depression, sometimes the pharmacological approach is absolutely needed. It can be life-saving for the patient. Also, depression in late life is a risk factor for developing subsequent dementia. Risk factors, when we talk about suicide specifically, that you need to keep in mind: physical illness, terminal illness, uncontrolled pain, personality disorders, prior suicide attempts, and family history of suicide. So these are, in older adults, they're some of the main risk factors that we want to keep in mind. And what are some of the possible causes of late life depression? There are several causes, as we know. There could be genetics. There is a genetic component. We don't know how much that may play a role in that particular patient. But there's definitely there can be a genetic component. Endocrine changes, motor changes, the presence of medical illness. We keep emphasizing this, but this is why medical illness across the board is a risk factor for depression and also for suicide. Cognitive impairment, the presence of other psychiatric disorders, as we said now numerous times, stressful life events, and chronic stress. Now, the studies are now beginning to focus on some really interesting aspects related to the some cerebral damage that may be related. So for those of you who are interested, the field of neuropsychiatry is providing some interesting insight into the understanding of late life depression. And so, for example, damage to the frontal subcortical circuitry, specifically the striato-pallidothalamo-cortical pathway, either due to neurodegeneration or cerebrovascular disease, is implicated in some subtypes of late-life depression. Also, we need to keep in mind that subclinical cerebrovascular disease may also affect the susceptibility and expression, susceptibility to and expression of depression. In particular, cerebral atrophy, subcortical deep white matter, and periventricular ischemic lesions that can be seen commonly on brain imaging may be implicated in the development of depression. Other radiologic findings in late-life depression that are important here to mention are increased ventricular brain ratios and decreased volumes in specific brain regions. So this is a really interesting area because there are some underlying changes in the brain, some of which can be evaluated on scan, so they're relevant to the development of late-life depression. And as we know, the classification in the DSM-5 includes major depression, and of course, I'm not going to go through the criteria, as you're familiar with that. But just keep in mind that major depression in later life is more likely to become chronic, and recovery may be more transient. Relapses are more common, so the risk of relapse in older patients and the chronicity is really significant in older patients. There's also the persistent depressive disorder, dysthymia. Keep in mind that older patients should fulfill, to give this diagnosis, older patients should fulfill the same DSM-5 criteria for persistent depressive disorder than as younger patients. Elderly patients with late onset dysthymia have a higher prevalence of cardiovascular disease. But otherwise, they're similar to older patients with late onset major depression. Just keep in mind that it's not necessarily benign, because dysthymia, like I said, have a higher association with cardiovascular disease. Minor depression is also called subsyndromal depression, and these are patients who, as you know, do not meet all the DSM-5 criteria for major depression because the symptoms are too few or the duration of symptoms is too short. I would say that minor depression in late life is more prevalent than major depression, but minor depression is important in older patients, in the older patient population, because these patients suffer a disease burden that is really comparable to patients with major depression, have poorer health and social outcomes. They have similar levels of functional impairment, and they also are at high risk for developing major depression, actually, and suicidality. Psychotic depression really presents with psychotic features. It could be delusions or hallucinations. And then vascular depression, which is depression that may develop after an acute cerebrovascular event. For example, this is often referred to as a post-stroke depression, or may develop in association with chronic ischemic changes in the brain. And when this is the case, it's called vascular depression. So it's really important to keep in mind whether this is a result of a cerebrovascular event or it's vascular depression due to chronic ischemic changes in the brain. And then, of course, the development of depression as a complication of Alzheimer's disease is increasingly recognized. Some of the diagnostic challenges in recognizing depression late life are concurrent medical illnesses. And in what ways is a challenge? Well, many of symptoms, the normal symptoms of medical illness, such as advanced cancer, for example, such as fatigue, inability to concentrate, low appetite, weight loss, what we call the somatic or endogenous symptoms of depression, are common in medical illness, and so they're a normal and expected consequence of illness. So if we use those symptoms to diagnose depression, we may overdiagnose depression. So there's an overlap between somatic symptoms of depression and somatic and symptoms, expected symptoms of medical illness, that can create confusion. You may or may not be aware of the Endicott's criteria for medically ill. This is an early model in the late 80s, and it's called the substitutive criteria, substitutive approach. And basically what Endicott suggested was looking at the criteria from the DSM to replace every somatic symptom with a psychological symptom. So instead of inability to concentrate, for example, fatigue, you would really replace that with a depressed appearance, focusing on depressed appearance, focusing on anhedonia, focusing on the irrational guilt and sense of worthlessness, the inability, unwillingness, really, inability to be cheered up in any way, the rumination, especially the negative rumination, ongoing sense of doom. So leaving aside, discounting a little bit the medical symptoms and focusing on the psychological symptoms may help, and it does actually, because there's less confusion. And patients who are depressed and also medically ill certainly do exhibit, do experience a lot of psychological brooding and self-pity, worthlessness, the guilt, being undeserving. There could be also that kind of self-destructive anger, inability to make decisions, apathy across the board, which is different from fatigue. So keep that in mind. It's an early approach, but whatever the approach you can develop when you assess a patient, an older patient who's also medically ill, just keep in mind that we should really focus on psychological symptoms of depression. So that also means that assessment tools that are traditionally, historically used with the younger population or the non-medically ill, such as the Beck Depression Inventory, may not be the most appropriate if you work with a medically ill population, because part of the assessment includes, all the some of the somatic symptoms of depression. There are also medication side effects that create this overlapping of symptoms. There are some medications that can actually induce or mimic depressive symptoms. There could be impaired communication skills. Patients with cognitive decline may not be able to really express, to share the psychological burden of depression. There may be multiple somatic complaints. They may actually be the part of the expression of depression. This could be due to cultural reasons, where, for example, it's not acceptable in some cultures. There's a lot of stigma associated with just the word depression, because the patient may think, well, I'm going crazy, or they think I'm going crazy, or it's just not the way they think about things. They conceptualize, this. But what is acceptable could be the expression and manifestation of somatic complaints. So depression may be expressed through persistent stomach pain and pains and aches. And pains and aches are generally also part of major depression, but some patients may just not relate to any of the psychological symptoms. And the perceived stigma is, of course, always a problem. So some of the diagnostic workup involved that often physicians recommend in late life depression include the use of depression screenings, even though I think personally the clinical interview is the gold standard, honestly, especially when working with a vulnerable population. If you don't have time, of course, and you want to do a quick screening, that's perfectly appropriate, of course, and we'll talk about that in a moment. But when I think about assessment, the assessment process with this population, and especially if they're also medically ill, I think about assessment as a therapeutic assessment. So during the time of the assessment, I'm gathering information, but I also should be able to give something back at the time of the assessment, something back in terms of reassurance or reframing or presenting possibilities and a possible solution and a treatment plan, or just really providing them with a kind of a general roadmap where, you know, we're taking care of you, and this can all be contextualized. We know how difficult this may be. So experiencing depression, this is the way depression affects the way you think and the way you feel, and this is why this is so uncomfortable, but we can definitely improve this. And so whatever you reframe or explanation you can provide, it's so important. And, you know, perhaps because I do a lot of work with patients who have limited prognosis, we know that you know, time is so important, right? They become exquisitely attuned to the passage of time, because time, well, how much time do I have? I don't have enough time. And so I think it's important that any time we have an encounter with a patient, that we use the time in the best way possible, that it's never just obtaining information, but there's that component of giving back. And I find that the clinical interview is really often the best tool for that, offers the best opportunity. Blood studies sometimes can reveal deficiencies like thyroid abnormalities, deficiencies in B12, folate, etc. that can be an underlying cause of depression. ECG, brain imaging, sleep studies. The sleep study actually can be very relevant. We'll talk about it more a little bit later, but sleep deprivation, sleep disorders, are increasingly being associated with the presence of depression, because if they don't get any sleep, or they have sleep apnea, they don't rest, and this even without being bereaved or major stress life event, they may really become chronically sleep deprived, and depression can develop as a consequence. So a sleep study, especially if they say they can sleep, they don't sleep well, should be considered. There are several screening instruments that are used. So what is the most appropriate screening instrument? Well, there isn't really one. It depends on the particular population that you're working with, your agency, the time that you have, your level of comfort. But I've listed a few that are commonly used. The 2-question screen, you're probably familiar with this. During the past month, have you been bothered by feeling down, depressed, or hopeless? And during the past month, have you been bothered by little interest or pleasure in doing things? I personally like this 2-question screen because it really speaks to the subjective perception. So patients may, as they decline, especially if they're ill, they may be less and less able to do things that they like. But I've noticed that as part of a preparatory grieving process that I described earlier, patients, you know, may start contemplating their own death and dying, and they may kind of slowly detach from even loved ones and things that they used to like to do. So there's also kind of an understandable psychological process they may go through. But here the question is, well, have you been bothered by the fact that you have little interest? Have you been bothered by the symptoms? So is this ego-dystonic or ego-syntonic? Is it something that is part of a different type of development, or is it something that is creating distress? So it's kind of neat. And then the geriatric depression scale, the 5-item question. Are you basically satisfied with your life? Do you often get bored? Do you often get helpless? Do you prefer to stay at home rather than going out and doing new things? Do you feel pretty worthless the way you are now? A good screening tool, even though the question, do you prefer to stay at home rather than going out and doing new things, certainly would not apply to a person who's really ill because they couldn't go out even if they wanted to. But what they may be able to say is that, well, even if I could, I wouldn't care. I don't even care about being ill. I wouldn't care if they could find a cure for my cancer tomorrow. I couldn't care less. I don't, complete disengagement. The PHQ-9 also is often used in primary care settings. The Cornell and the Center for Epidemiological Studies of Depression Scale 20 items, generally I tend to avoid longer screening tools because, again, they can be burdensome for the patient, but they're sometimes utilized in clinics where patients are relatively healthy and they can engage and they may actually like to do that. So, again, the question is, who is the patient that you are working with? The treatment of late-light depression always involves addressing comorbid conditions. Needs to be focused on tailoring pharmacological interventions that really are focused on who is the patient. It's important to monitor therapy very, very closely, close follow-ups, assessing suicidal ideation and making it really normative without euphemisms. If those of us who work in primary care may have the opportunity to work and work with physicians and provide some level of, I don't want to say training, but some training actually sometimes in terms of how do you engage in these conversations, how do you ask, and how do you do so with comfort and ease, and kind of making these questions as part of your normal conversation, and not just, you haven't thought about killing yourself, have you? And then moving quickly on to the next question. But really, if we are concerned, to kind of slow it down and allow the patient to verbalize any thoughts they may have had. The question of whether looking at the medication, doing a thorough medication review, and noticing if there are any medications with depressant side effects, if there is a presence of alcohol abuse, and considering, of course, it's important to consider medical conditions that are associated with depressive symptoms. Psychotherapy plus somatic therapy could be medication or ECT in intractable depression can be effective. And again, ECT, some of you may not be familiar with the use of ECT in older patients for intractable depression, but actually it may be an important therapy to ensure safety, especially in life-threatening situations when patients chronically suicidal and they haven't responded to any other therapy. Let's remember that efficacy of antidepressants may be reduced in late life, and exercise, as we know, is helpful, especially in minor depression, but it may be difficult to comply for patients. So we also want to make sure that the recommendations do not ever create a situation where the patient is kind of setting the patient up for failure, which would make them feel worse. So continuing on our conversation about pharmacological management of late-life depression, we need to keep in mind that many older patients are reluctant to take medication for depression, and I'm talking about patients 60 and older. They may be afraid of medication dependence. They may reject the concept of depression as a medical illness, so there's a lot of stigma associated with that. It's always an important reframe to reframe depression as a medical illness, because it is. but many don't really accept that. They fear that medication will change them. It will inhibit their emotional reactions. They may have had a negative experience with medication, and older patients have a life time of experience, so many tend to be very set in their beliefs because they have developed these beliefs over a period of time. And so if we want to challenge these beliefs, it has to be done gently, without an agenda other than providing information and working with the patient. So even more so, trust is important because it can be the only thing that can allow us to identify barriers to treatment, and also ways of managing those barriers. The literature has shown that antidepressants are effective over placebo, so we know that in the treatment of depression, so they are indicated. But most of the studies have found little difference in efficacy between medication classes. There was, in several studies, a higher withdrawal rate due to side effects for patients treated with tricyclics compared with SSRIs. So the choice should always be made based on side effect profile, which can be used to the patient's advantage. Typical example that you're probably all familiar with, mirtazapine for patients who are also anxious and can't sleep. So it may have a component of depression. So that's where the sedation that is undesirable, perhaps in another patient, may be appropriate and used to the patient's advantage, or a patient with whose depression has translated into significant weight loss, while mirtazapine may be the most appropriate because we're using the adrenergic and noradrenergic effect, but also we are capitalizing on the side effect profiles, the sedation and the sedation and augmentation of appetite, increase in appetite. Now, monotherapy is preferred, starting with one medication and titrating it slowly. Initial medication doses should be cut in half in general in older patients, and sometimes even a third. Okay, so it's important, and making changes very slowly. Monotherapy is preferred because it creates, well, less burden for the patient. If there are side effects, it's important it's easier then to understand, well, where are these side effects coming from? What is causing? So you never want to make several changes at once. But it's also important to titrate appropriately. So starting slow at a low dose, or even a half, or even a third, doesn't mean that the patient should be at that dose, at that starting dose for years, and then we're going to expect some kind of results, and the patient may not have any results. So the titration is often a problem in primary care. So we see patients who were started on 25 of sertraline or 5 of escitalopram, and they're kept at the same dose of medication. There was never a titration because the provider was afraid of side effects, and so just prescribe the medication. Maybe they felt comfortable that the patient was on an antidepressant, when in fact the patient is likely not to benefit from it. So titrating appropriately, but following up very closely. So after every titration, every change, there should be another appointment, maybe 1 to 2 weeks. Sometimes 1 week is better at the beginning if possible, especially if the patient is concerned or is anxious about side effects, to reassure and monitor and educate. Medication typically takes up to 4 to 6 weeks to show efficacy, but in older patients, this could even take longer. An antidepressant response may not occur until 8 to 12 or even 16 weeks of therapy. So one thing that I would like you to keep in mind is that generally the literature has shown that patients who didn't show any improvement at all by 4 weeks of treatment, in studies, these patients were unlikely to respond even after 8 additional weeks. So after 1 month, it would be appropriate to consider an early change in the treatment plan. The duration of treatment in late-life depression is very important. So for the usual course of treatment for the first episode, the first lifetime episode of major depression, is 6 to 12 months beyond the time of achieving full remission. So treatment needs to continue for 6 to 12 months after remission. And this is particularly important in older patients because they have a higher risk of relapse than the younger population. One thing it's important that we do when the treatment is when treatment stops, pharmacotherapy stops, monthly therapy sessions could be useful they haven't been shown to be useful to prevent relapse, but they can be useful to teach patients to identify perhaps a recurrence of symptoms so that they will go to their primary care provider and report, okay, I'm feeling this way again. I mean, the negative thoughts are coming back, and a little bit of hopelessness, and so that they, kind of quickly address any recurrence. Because again, the higher the risk of relapse is really high. So remember, monthly therapy, monthly psychotherapy after treatment has not really been associated with a significant decrease in relapse in older patients, but I think it can be very helpful because it's important to maintain a connection so that if medication needs to be restarted or we were to stop prematurely, it can be restarted. Hopefully the patient had already positive associations with the medication, so it shouldn't be, it is possible to start again. So let's now review medication, pharmacological agents used for depression in late life. Okay, so SSRIs are considered the first line of treatment of depressive disorders in older adults, and this is because they're better tolerated, they're easier to use, they're generally safer, especially in overdose. However, they do carry side effects, as we know, and especially some of these side effects are especially concerning in older patients, and these include Parkinsonism, akathisia, anorexia, sinus bradycardia, and hyponatremia. And so, as you probably know, the syndrome of inappropriate antidiuretic hormone secretion is not dose-dependent. So there is a risk with any dose of SSRIs. There is an incidence of about 12% with SSRIs. The first sign can be a change in mental status. So one important recommendation with older patients is to check serum sodium before you start an SSRI, and also you check it at week 1 and week 2 after treatment begins. So this is important, particularly important in older patients. Any change in mental status should be thoroughly investigated. It could be and what the cause can be, and sometimes they may be a result of maybe associated with the SSRI. So you should notice a change in week 1 and week 2 after treatment beginning. If there is a change from baseline, that would be a concern. Now, fluoxetine, I listed some of the characteristics because they're important for taper. Fluoxetine has a long half-life, so in generally, if you have to discontinue, we don't need to do a really long taper because of the long half-life. Paroxetine of the SSRIs is one with the most, the one that has more anticholinergic side effects, so probably not recommended because of the anticholinergic. Sertraline, generally well tolerated. Citalopram and escitalopram, remember the warning, not more than 20 milligrams a day in a dose. This is important. We'll talk about it later as well. SNRIs, mostly venlafaxine and duloxetine. There's also desvelfaxine. But these two medications are used not only for depression, but they're also effective moderately effective in neuropathic pain. So unlike SSRIs that really don't have independent analgesic properties, SNRIs appear to have some independent analgesic properties, like tricyclics, for example. So they can be effective in pain and depression. And because tricyclics have so many anticholinergic side effects, more than SNRIs, probably, and tricyclics are no longer even recommended as a second or as a first or second line, SNRIs are a good alternative. But keep in mind, of course, that, as you know, venlafaxine also lowers the seizure threshold. Duloxetine may cause a lot of GI distress in patients, but most importantly, if you need to discontinue venlafaxine, the taper has to be done very, very, very slowly, because the discontinuation syndrome can be very distressing and risky, in fact, in older patients, because they get dizzy and they can become delirious, the akathisia. It can be very difficult. Bupropion, probably appropriate. It's more activating, so more appropriate if the patient is feeling as a really an endogenous depression that causes a lot of fatigue. And mirtazapine is sedating, appetite, can have an appetite stimulant effect, and should always be initiated. All these medications, any SSRI should be started very, very slowly. It's so much better for the patient to get slowly adjusted to side effects. Now, there is an increased risk of suicide in men 66 years and older in the first month of treatment with an SSRI compared with other antidepressant drugs in one study. But this speaks to the importance of monitoring and really checking in with the patient when a medication is started. So I would say probably a week later if possible. If there are issues with insurance, definitely 2 weeks after the initiation of therapy and after each increase. If there is an issue, there could be, sometimes the nurse can do a check-in with the patient, depending on your setting. A quick phone check-in is something that in my setting I could always do. If that's not part of what you can do, find some other way to check in, and let's make sure that the patient, the older patient, doesn't hold back on describing side effects for the fear of disappointing us. So it's very important to be neutral. I mean, we want to generate positive expectation about medication, but we don't want to be biased, and that is not our agenda. We're kind of neutral. I mean, everything is started on a trial basis. So to summarize, SSRIs are the first line of treatment if there isn't a significant risk for falls, I would say. Side effects include Parkinsonism, akathisia, anorexia, sinus bradycardia, we already mentioned that. Increased risk for fragility fractures, important to monitor for suicidality, especially the first month. They're probably not more efficacious than other antidepressants, but they're better tolerated, and this is important. ECT in some cases can be better for patients with intractable depression who've tried a number of therapies, and sometimes it's the only thing that can actually maintain patients relatively safe and functioning. The citalopram and escitalopram warning, this is important because there is a dose-dependent QT risk of QT interval prolongation. So in patients over 60, do not exceed 20 milligrams a day. Some of the studies that are available were done on 40 milligrams prior to the guidelines being published and the warning being published, but it's very important not to go over. Now, keep in mind that SSRIs and citalopram and escitalopram can also worsen glaucoma in patients. SSRIs can have these problems. They have some anticholinergic effect, of course, but not nearly as much as tricyclics. SNRIs are generally the second line of treatment for treatment failure with an SSRI. They're also, as I mentioned, effective for comorbid pain. So let me go back for a second. SSRIs, as I mentioned, don't really have any independent analgesic properties, but they may be effective in patients with pain because they may relieve the depression, the somatic, the pains and aches that are more part of a depressive syndrome than a pain syndrome. But SNRIs can be indicated for comorbid pain. Duloxetine has been can be difficult to tolerate in terms of the dizziness. I mean, in some studies, patients have withdrawn. It's often recommended to take it on a full stomach to decrease the likelihood of GI distress. Venlafaxine, some studies have shown that it's not as well tolerated as sertraline, but certainly if there is a pain management issue, it could be tried. But remember, the discontinuation syndrome is really very, very difficult, very challenging for patients. So the taper should be done very, very, very slowly. They're generally safe, but there is a dose-dependent risk for diastolic hypertension, which is something to consider in older patients who may already be on medication for that. Among the atypicals, we want to talk about bupropion, which importantly is metabolized in the liver by the cytochrome P450. So we need to keep that in mind, and it's activating. So patients may actually become more anxious. We want to make sure in our assessment that we understand what is the core component of the depression. So is it mostly an endogenous depression with a lot of fatigue and lack of motivation? Is there an anxiety component? Because if there is an anxiety component to the depression, escitalopram may be a better a better choice because it's also effective in generalized anxiety disorder. So we don't just want to activate. If there's some anxious rumination, that sometimes gets worse with bupropion, but make it better with escitalopram. So something to consider. Of course, we don't want to use bupropion, as you know, in patients with seizure disorders, patients who are also using benzodiazepines or other CNS depressants, alcohol detox. The dose-dependent diastolic hypertension is a concern in the older patient. Trazodone is used in a variety of settings, mostly, actually not as much as an antidepressant, but it's used frequently to address sleep disorders at a low dose. And mirtazapine has a very important dual action, serotonergic and noradrenergic. It's also used as a second line, but sometimes for some patients, so as I said, may have lost a lot of weight, they may be anxious, I would definitely go to mirtazapine as a first line. So just look at who the patient is. It may be used in patients with Parkinsonism, essential tremor, nausea from chemotherapy. Of course, the risk of serotonin syndrome is present, but again, it doesn't necessarily have to be a second-line treatment. Tricyclics are no longer considered first or second-line agents for the treatment of depression in older patients, but they can still be useful if there is a failure with other antidepressants. A few studies have suggested that tricyclics are actually more effective in depression that has melancholic or delusional features. It is interestingly the only class that is shown to reduce risk of relapse after ECT. But again, extreme caution should be used with patients with cardiac conduction abnormalities, narrow angle glaucoma, urinary retention, and constipation. Like I said, I've seen patients on escitalopram have some worsening of their glaucoma, pre-existing glaucoma, but not nearly as much as tricyclics. They can worsen confusion in Alzheimer, but they are certainly, they can be helpful in pain syndromes. So sometimes they're used in younger patients for that. They're started as a first line of treatment in pain. In older patients, unfortunately, this is not recommended. So mostly what you see nowadays, I think in most practices, you see patients who were started on a tricyclic and they were doing well, and they tolerated it, but generally they're not chosen as a first line. And these are the tricyclics, as we know. So let's talk for a moment about psychostimulants. Psychostimulants are adjunctive medications. They may have a role in the treatment of depression, and some studies have shown that simultaneously prescribing an antidepressant with methylphenidate at the onset of treatment may improve outcome. And this was a study of some studies with patients about a mean age of 70 years with unipolar major depression. But I would say it's important that ECG be performed at baseline, and patients with atrial or ventricular arrhythmia or acute ischemic features have to be excluded, of course. That would not be appropriate because of the risk involved. Stimulants can lead to several adverse cardiac effects. So that's those are what I'm describing are older studies where the patient was receiving citalopram and methylphenidate, and citalopram doses ranged from 20 to 60. This was before the warning. But let me talk to you about another use, another role for psychostimulants, and this is at the end of the slide here. I have a role in palliative care, because psychostimulants sometimes can be actually first-line treatment, pharmacological treatment, in patients with a life prognosis, life expectancy of less than 2 months. Because what would be the point really of starting an SSRI if the patient is already very debilitated, very ill, life expectancy 2-3 months, less than 6 months, and the expectation that they will be able to benefit from the antidepressant effect is really low. There would have to be a titration process. So in those cases, the patient will still benefit, and the patient, as part of the patient's goal, is to be engaged and have more energy. You know, we have patients who are near end of life. When I say near end of life, this could mean several months, let's say 6 months or less, right, of life expectancy, even 3 months or less. And they feel that their depression or lack of energy is interfering with their ability to connect with loved ones, and they would still like to live as fully as they can until they die. And in these cases, considering a psychostimulant starting at a very low dose, of course, has actually provided good results. They're relatively effective, relatively safe. Of course, they have to be used with caution, but the improvement can be seen in 24 hours, and I've seen this many times. The patient feels and appears brighter, more engaged, more energy. Of course, it's important to monitor, and generally we're talking about patients who are receiving either hospice care, so there's medical monitoring, or patients who are hospitalized, but also patients who are still ambulatory, but they have a life expectancy of 6 months or less. Sometimes they benefit from psychostimulants as a first line. So this is something to keep in mind. Those of you who are not familiar with this use of psychostimulants, they do have an antidepressant, not your typical antidepressant effect, and not the same mechanism, but they can improve gait and stamina and fatigue and concentration in patients, and this can translate in an improvement in quality of life that is very important, can be really critical for them and their loved ones. Now, MAOIs, of course, as you know, are rarely used except when previously initiated or tolerated, and when patients are resistant to all other antidepressants. They do have some proven benefits, though, in atypical depression, panic disorder, mixed depression, anxiety states. The special dietary restrictions to prevent serotonin syndrome, of course, are a problem, and so this is one of the reasons why they are generally they're rarely used. Other common side effects, particularly concerning in older patients, are orthostatic hypotension, activation, and insomnia. However, unlike tricyclics, they are relatively devoid of cardiac conduction effects. So that's not necessarily a concern, but I believe you probably won't see a lot of patients on these medications. The inhibition of the cytochrome P450 is a very important topic. Actually, studies have come out saying that, well, it's not actually clear how important it is, how impactful this is on overall pharmacodynamic and pharmacokinetics, but we certainly have to keep it in mind and always choose a medication that has a low low impact or low effect on the cytochrome P450. So bupropion is moderate. Now you can see citalopram, duloxetine, escitalopram low. Fluoxetine and fluvoxamine are high. Mirtazapine is low. Paroxetine is moderate. And sertraline and venlafaxine is low. Older patients are probably on other medications that are metabolized through the same pathway. So it's particularly important to choose the drugs that are less problematic. And this is why sertraline, mirtazapine, escitalopram are commonly used with older patients. Venlafaxine as well, because it's a low inhibitor, but there are other problems with venlafaxine. So if the patient doesn't also have pain syndromes, neuropathic pain or other types of pain, they're generally not chosen unless there is a failure of treatment with SSRIs, in which case. And other adjunctive medications are aripiprazole and quetiapine. Aripiprazole has been used in older patients for treatment-resistant late-life depression. And studies have shown that it can be efficacious. However, it does cause more akathisia. Weight gain is also more of a concern. And quetiapine, well, quetiapine is problematic because the risk of short and long-term side effects makes it not a first or second line of treatment, even though some studies have shown that it can be effective for major depression in older patients. Sedation, dry mouth, extrapyramidal symptoms are some of the problems, some of the common side effects of quetiapine. And with all second-generation antipsychotics, there is an increased risk for mortality in older patients, so they're really rarely used. You may see patients on 25 of quetiapine for 25 milligrams for insomnia, but again, not appropriate probably for long-term use because of the risk of mortality. As you know, there's been a lot of research done to try to understand the relationship between antipsychotics and increased risk of mortality in older patients, especially in nursing homes. So the prescribing practices have changed. And as I think I mentioned at the beginning of the lecture, antipsychotics are used rarely, and they're used only when the patient is at serious risk for harming self or others. So this is just summarizing adverse effects. And again, these can be very problematic in older patients who may already be weakened by a medical condition. One quick comment, of course, it's kind of obvious, but let's not assume that the sexual side effects are not going to be a problem for older patients, because as you know, for many patients, sexuality is something that older patients, that they continue to be very connected to, and they are very sexually active way into their even late 80s and 90s. And that's one of the, can be an important source of pleasure and meaning and connection with their spouses, with significant others. Compromising that may trigger even more depression. So this is something that we need to carefully consider and have that conversation. And in my experience, primary care providers tend to not have that conversation. Many providers, relate to older patients as if they were, grandfathers and grandparents or parents. And so there's that kind of relationship and bias that can prevent them from exploring these important aspects. So let's just keep that in mind. And now we're going to start with our next topic, which is anxiety disorders. Okay, so anxiety disorders in late life. So we'll talk about anxiety and anxiety disorders. These are common in late life. Generalized anxiety disorder is very common. There's a high comorbidity with late life depression, so patients can experience both. Although anxiety symptoms are generally more stable and over a lifetime. So you may have a patient who's been very, very anxious for many years. And anxiety symptoms are definitely a risk factor for major depressive disorder. Unfortunately, there's positive research when it comes to older patients, and this is true across the board, not just related to pre-marketing trials of medications, but also treating anxiety disorders in late life. In serious illness, anxiety can become a significant challenge, and I'll focus on that for a moment. Now, assessment is always crucial because anxiety does affect the way patients engage with their providers, the way they receive information, the way they process information, the way they follow or don't follow the treatment plan, and the ways they look at treatment. So in older patients with comorbid medical illnesses, this is even more important. It can have a really devastating effect. And let's talk about anxiety and advanced illness for a moment. Now, symptoms of anxiety are common, over 70% in patients who are seriously ill. Now, anxiety, as we know, can have an adaptive function. So if we have a 70-year-old woman who was just diagnosed with ovarian cancer, or a 65-year-old, 75-year-old man just recently diagnosed with prostate cancer, and they also have other comorbidities, or not necessarily. Think about receiving a diagnosis of serious illness when you're older. Patients need to mobilize a tremendous amount of energy, physical, cognitive, psychological energy to navigate the medical system, make the medical appointments, deal with diagnosis, process information related to treatments, what are my options, actually make those appointments, deal with treatment, deal with side effects, make decisions as their situation changes. Or patients who've been dealing with a chronic illness for many years. Could be chronic COPD, congestive heart failure. And as these illnesses get worse, as the disease continues to get worse, their anxiety may increase. So some anxiety per se, as in terms of behavioral activation, like forcing the patient to engage, can have an adaptive function. But in most cases, it has to subside when it's no longer needed. Patients, for example, can get very anxious before a scan. Patients with cancer, actually, there's something called scanxiety, right? Which, even patients who have been in remission for years find that over time, instead of becoming less anxious about a routine scan, they maybe find that they actually get more anxious. This is all relatively normal and understandable. It can be contextualized, to their situation. But generally, anxiety then decreases. The level of arousal decreases, and the patient is able to engage in their life and continue on. But when the patient, the anxiety is persistent, is non-adaptive, creates suffering, interferes with function, it's important to treat it, whether it meets full criteria for a DSM anxiety disorder or not. In palliative care patients, the prevalence of anxiety disorders is about 10 to 30%. Now, think about this. Palliative care is provided at all stages of illness. So people can be receiving palliative care, which is basically active, aggressive management of physical, psychological, spiritual distress for years. So it's important to understand what the patient's situation is. They may be feeling a lot of anxiety, not because the end of their life is necessarily around the corner, but just because it's very difficult. Managing the disease, navigating the medical system creates ongoing sources of anxiety and stress. Of course, in the development of anxiety, there are biological, neuropsychological, developmental, and factors. Excessive worrying is really one of the hallmark of these of the development of anxiety, and it can starts often with on a cognitive level with this ongoing rumination, but many patients experience it as primarily a physical symptoms, kind of a sense of upset and GI distress, for example. So it's very important that we do a thorough assessment. And older patients, again, are vulnerable, are more vulnerable. They may have impaired communication. They may not be able to relate to anxiety. They may feel physical discomfort. They don't think they're anxious. But the burden of untreated anxiety is significant. It causes ongoing emotional suffering. Studies have shown it causes an interest in hastened death. The patient who's highly anxious has a decreased ability to understand medical information. Patients who are highly anxious have an anxiety disorder or unmanaged anxiety, even if it doesn't fully meet criteria for a disorder, have a less trust in their physicians, so they don't trust their physicians. They have less expectation, a decreased expectation that their symptoms will be adequately controlled at the end of life, and they are more likely to believe that they will be offered therapies that really don't benefit them at all. So imagine an older patient who has a chronic advanced illness, who is often contemplating what will my end of life be like, and imagining having all this negative imagery about not having their symptoms adequately controlled at the end of life. Patients are afraid that they will be in pain. Patients with congestive heart failure sometimes report this fear that they will kind of drown, and COPD, I cannot breathe, I will just die. So this can be really terrible, terrifying for patients. So the point is, anxiety, again, is not a natural, it can be understandable, it can have an adaptive role up to a point, but it's not a normal consequence. It's not something that patients should have to deal with. It's something that should be managed and treated because of the incredible burden that it causes. And so we have all the clinical manifestations of anxiety. You are very familiar with all this, so I'm going to spend just less than a minute. But just remember that for some patients, the only response is really the manifestation can be really autonomic. You may see diaphoresis, diarrhea, nausea, dizziness, tachycardia, and tachypnea. And so it becomes more complicated when you have a patient who's medically ill, who's experiencing the symptoms that could be caused by the illness itself, that could be caused by medication. And in some cases, they're primarily a manifestation of anxiety. So important to do a very thorough assessment. Avoidance, rumination, catastrophizing, constant exposure to negative stimuli based on negative mental imagery creates ongoing challenges for these patients, especially when they're older and they may not have an advocate or somebody who speaks for them, undermining relationship with providers and creating more distress for the patient. So there's some identified medical causes of anxiety. It is associated with specific conditions. For example, patients with lung cancer and COPD are more likely to experience anxiety. It's also associated with anticipatory nausea and vomiting, with the use of corticosteroids, drug intoxication, metabolic disturbances, and also encephalopathy with systemic infection. Now, corticosteroids are a common, well-known, recognized cause of anxiety. If the patient is, well, let me say this. The first step is always to try to reverse and address medical conditions or medication. So if possible, the offending agent can be replaced. If it cannot be replaced, for whatever reason, and the patient's level of functioning, cognitive functioning, psychological functioning allows, it could be important to provide a context and let them know that this is not them. They're not losing their minds, as many patients say. They're not losing their mind. They're not losing their coping skills. But this is something that is caused by an external, it's coming from an external source. It's kind of, using a narrative approach. Anxiety is, the medication. Anxiety is coming. When anxiety comes because of the medication that I'm taking, then I'm feeling this way. Kind of externalizing and making sure that the patient doesn't think that they're basically losing their coping skills. This can help some patients better manage side effects. Of course, as I mentioned, you need to be sure that the patient can actually engage with you at that level. Other medical causes of anxiety, of course, an pre-existing anxiety disorder that perhaps was well controlled or kind of stable, and then there's a medical diagnosis, a life stressor, and then the patient begins experiencing an exacerbation of symptoms. Uncontrolled pain, as we mentioned, related to late life depression. We need to make sure that the patient is relatively comfortable and that symptoms, physical symptoms, are controlled before we even diagnose a patient with an anxiety disorder. Endocrine disorders, withdrawal syndromes, delirium, of course, psychotic disorders, and cognitive impairment. These are all medical causes of anxiety that should be evaluated and considered in the treatment of older patients. Because, again, they have several comorbidities, they take several medications, and may have problems in taking medications that are causing anxiety. So they're more likely to be susceptible to these problems than younger patients. The pharmacological management involves the use of antidepressants as a first line of treatment. And this is important. So if the patient is not hospitalized, it doesn't have a very, very short life expectancy, the general management is to use an antidepressant, and that's the first line. Benzodiazepines, as we know, are not indicated for long-term use. Of course, we know the risks, and it's also important that primary care providers do not convey, they don't give something to patients and then try to take it away. So remember when we talked about bereavement, somebody who's so anxious, it cannot sleep, and there could be a role for a short-term use of benzodiazepine. It should be very clear in the communication to the patient that this is only short-term, this is only crisis intervention. Because when a provider has been managing long-term anxiety with a benzodiazepine, it's going to be very difficult for the patient to accept switching to a different medication, to a different type of management. So for long-term management of anxiety, and this applies also to patients with serious illness, because as you see, I'm talking about the older patient in general, but then I really need to talk about patients with serious illness, because older patients with serious illness and advanced illness are commonly seen in integrated primary care and in different settings, of course. So the long-term management involves SSRIs, SNRIs to some extent. There's some indication that duloxetine and venlafaxine are also effective for anxiety, but they may also increase anxiety in some patients. So I would say this is definitely a second or third line. And they can be useful when there's, as I mentioned, mixed depression and anxiety and neuropathic pain. However, escitalopram, studies have shown, is a well-tolerated drug, also helpful in generalized anxiety disorder. So that would probably be a choice, a go-to. Sertraline, also well-tolerated. In some cases, if the patient has severe anxiety, because of the rebound anxiety, the excess, actually, the additional anxiety that can be caused by SSRIs at the beginning of treatment, in some cases, a benzodiazepine is initiated with an SSRI at the same time, and then the benzodiazepine is discontinued after a week, and then the SSRI is continued. But if we think that the patient has risk factors for misuse, abuse, or just really wanting to use sedating drugs, or there are existing risk factors and some more risk for falls and sedation, we should not consider benzodiazepine. However, they have a role, and in palliative care, they can be absolutely legitimately used for the management of for crisis intervention, acute anxiety reactions, panic attacks, patients who are hospitalized, patients at the end of life, patients on hospice. There's definitely a role for benzodiazepines to maintain, not to keep them sedated, but to control the anxiety. And antidepressants, sometimes, you know, the team may try mirtazapine, and that may not provide enough relief. So the concerns with benzodiazepines related to accumulation, side effect, toxicity are real, as we know. Medium-acting benzodiazepines can be helpful in nausea related to treatment, especially cancer treatment, panic attacks. Older patients who have a compromised hepatic function may do better with lorazepam. It's important to consider always a slow taper, sedation, memory loss, delirium, and the risk of delirium and confusion. So the slow taper should always be the norm also for patients who've been on this medication for some time. So short-term management, acute anxiety, and end of life. This is in the medically ill is generally the way we should look at prescribing the role for benzodiazepines. Of course, there's a lot of inappropriate prescribing out there, but this is really what we should consider. Long-term management, antidepressants are the first line of treatment. Other agents have been used some of them successfully, like gabapentin, for example, you probably know, but they have to be used with caution in patients who are also taking opioids because of an increased risk of mortality, and we'll talk more about that in the chronic pain lecture. Trazodone also has been used mostly for anxiety that's related to anxiety before sleep or sleep disorders. So that's one option, one use for trazodone. Mirtazapine, we already said that. Quetiapine, sometimes used at a low dose to promote sleep and decrease agitation and anxiety. Beta blockers have also been used, but there has to be caution because they have several drug-to-drug interactions. Anticonvulsants such as gabapentin are generally better tolerated than mood stabilizers. And they can be an alternative to antipsychotics in agitation, if the patient is experiencing agitation. Now, we mentioned gabapentin. Of course, gabapentin and pregabalin, both are used for pain and anxiety. However, so they certainly have an indication in neuropathic pain, and we'll talk about it more tomorrow, but they may increase depression. And the potential danger with opioids, this is a kind of a new development in light of recent studies, so we'll talk about that tomorrow. There should be more caution. They're not entirely benign, as some may believe, but certainly an indication of neuropathic pain and anxiety. So I wanted to kind of quickly read this case study, and as you listen to the lecture, you can read the slide and make all kinds of associations and hypotheses about how you would treat or how you would help this patient. She's a 71-year-old woman diagnosed with breast cancer 1.5 years ago. After a modified radical mastectomy with 8 out of 20 positive lymph nodes, she received chemotherapy, radiation, and is currently on hormonal therapy with anastrozole. Since the diagnosis, she's been feeling a constant state of alarm. She feels shaky and jittery. She's very concerned about the possibility of a recurrence and keeps imagining receiving the bad news from her oncologist. She feels very anxious about before any blood test or scan, and continues feeling anxious even after negative results. Over the past 3 weeks, she's been waking up at night with intense fear, palpitations, sweating, and shortness of breath. She cannot identify a trigger for the anxiety, but during these episodes, she's usually unable to go back to sleep and so watches television until morning. She then sleeps until noon. Upon awakening, she feels anxious and worried about having wasted the entire morning sleeping. So a lot of worry. We have a serious illness. We have a, the cancer was regionally, there was a regional spread in 8 out of 20 lymph nodes. So not entirely, not one of the situations where she was told, oh, you're cured, even though that even the term cured is so complicated, needs to fully be unpacked. But anyway, she received treatment. She's well managed on hormonal therapy, but she worries all the time. Constant state of alarm. She's shaky and jittery, and she's always expecting to receive bad news. And the problem is that this is not only applying to, the moments before she sees the oncologist or she gets a scan, but she's always worried. And at night, she's been having these anxiety attacks. She wakes up and she cannot identify a trigger for the anxiety because she's not necessarily thinking that she's dying, but this just happens, sweating and shortness of breath. So one of the things that we need to consider is that, again, there's the cycle of worry, and then she manages the anxiety attack by watching television till morning, and then she sleeps, but then she starts feeling bad and she wasted the entire morning. So there's constant worry, there's guilt, so definitely anxiety and depression. So she was diagnosed with generalized anxiety disorder and panic disorder. But certainly, even though she didn't meet full criteria for depression, what we can say is that the ongoing worry created depletion and would create depressive states, depressive symptoms of, not being able really to manage her mind. So she was successfully treated with escitalopram, which was started at 10 milligrams, titrated to 20, which is the maximum daily, and it was well tolerated, and lorazepam, 0.5 milligrams daily as needed, which she would occasionally take right after a panic attack. But interestingly, as she received psychoeducation about panic attacks, she learned to, she tried to wait longer and longer before taking the lorazepam, and sometimes she would just be able to manage it without taking it. Which was good. I mean, she was monitor her ability to just take it as prescribed was carefully monitored, but she never overused or abused. And so the goal was for her to kind of reclaim her ability to manage her life and live even with this diagnosis, and a little bit of the uncertainty, because when the cancer is originally spread, nobody can say whether it will come back. I mean, nobody can say whether it will reoccur ever. You know, it's unfortunately there is always a little bit of uncertainty. In her case, there was a higher level of uncertainty because 8 lymph nodes were positive, but she learned to live with this anxiety. The CBT component of therapy was focused on recognizing the negative self-talk, the negative rumination, and replace it with different imagery, positive imagery that were developed during the session. So she kind of had a tool bag of positive imagery that she could go to, and she actually had a list. And we also made a CD that described the different imagery so she could listen to it, because it was really hard at the moment of right after the panic attack, or when anxiety kind of took over. It was hard to intentionally go to a different place in her imagination, but seeing a written description really helped, and she would read it out loud and really focus on the sensations. And this was also part of a self-hypnosis training that was provided during the session, the therapy session, that really focused on improving her self-efficacy. But escitalopram, for the long-term control, long-term management of anxiety, and a little bit of that depression that would occur, depressive symptoms, and the lorazepam as a kind of a crisis intervention for crisis needs, which she never abused. But of course, and there was no significant risk for falls. So this is important. Okay, and our almost last topic is sleep disorders. So sleep-related complaints are very common in older patients, especially over 65. So more than half of patients who are individuals who are non-institutionalized report some degree of complaint about sleep, not being able to fall asleep. Mostly in older patients, the complaint refers to not being able to stay asleep. So the first step is to obtain a detailed sleep history, collateral information. We need to understand whether we're dealing with an insomnia as an independent disorder, whether it is the result of medication. We talked about corticosteroids. We talked about medication that can be anxiety-provoking. Why isn't the patient sleeping? Kind of obtaining a full understanding. You may or may not be involved in treating sleep disorders, but it's important that we understand the role of psychotropics, psychopharmacology, and how it can help these patients. Patients may experience excessive daytime sleepiness. They may have sleep apnea, narcolepsy, disorders of the circadian rhythm, so they cannot sleep, which means they cannot sleep when desired, and vice versa. So it can be a real large spectrum. I'm not going to focus too much on this because we want to really discuss the risks involved in some of the medications, some of the approaches that are commonly used. Now, aging does have an impact on sleep. So there are definitely recognizable effects they're normal. They're a normal consequence of aging. And not only the pattern, but also the stages, sleep architecture changes as individuals age. So this has to be understood. And for some patients, it's been a long-standing problem. They've had difficulty sleeping all their life, and it's just getting worse, or just too tired of it, or dealing with it. They may have been on different medications. For some patients, this may be actually an earlier, a more recent onset. For many female patients after menopause, menopause can actually bring some difficulty sleeping, not just because of waking up with hot flashes, but overall, they describe that the whole pattern has changed, and they may continue to experience these difficulties for many years. So let's talk a little bit about the sleep-related changes that are a normal consequence of aging. In phase advance, so sleep during the early morning hours is reduced, and peak sleepiness occurs earlier in the evening for many patients as they age, as we age. Sleep deficiency, so the ratio of time asleep to time in bed declines, and this is largely due to more nocturnal awakenings. So sleep may become less efficient. Sleep time related to the total time spent asleep decreases. So the patient may spend a certain number of hours in bed, but the amount of time where they're actually asleep may be a lot less. Overall, though, they may be able to catch up during the day with naps, so the overall time may be the same, but the time in bed, the sleep time in bed sleeping may decrease. Daytime sleep latency. So there is kind of a stereotype that there's greater daytime somnolence with aging. This may be true, but for many patients it's not true. There was one study that suggested a reduction in sleep propensity with aging. And another one that showed that actually older patients can tolerate the sleep deprivation better than younger adults. So it really depends. For some patients, though, this is definitely an issue, and they have greater daytime somnolence. And many older patients may actually feel that the time required to fall asleep at night is slightly increased. Many report that it's unchanged, but overall, this is one of the expected changes, that the required time to fall asleep at night, so the nocturnal sleep latency, is increased. We discussed the changes in sleep architecture. We certainly know that the time until the first REM movement, the first REM period, becomes shorter with age. The percentage of time spent in REM sleep decreases, even though modestly. And so there are some changes that should be expected, are generally part of the aging process. Most adult patients complain of difficulty maintaining sleep. If they sleep less time at night, and their sleep is less efficient, for many patients there'll be increased daytime sleepiness, even though we know that for many patients that's not the case, and propensity for napping. So the idea and the myth that I discussed earlier, that patients get sleepier during the day, so it's more likely to take naps, may be a myth, because some studies have not demonstrated this, have actually shown the opposite. So the point is that when patients fall asleep during the day, and they take frequent naps, so they seem to be falling asleep at the drop of a hat. Well, that may not be a normal consequence of aging. That may be something that may need to be investigated. So we want to make sure that we don't accept some of the biases or the myths or the stereotypes that have been associated with aging. But the reality is that most adult patients who visit their primary care provider will complain of some difficulty or another related to sleep. And there's some dissatisfaction about the quality of their sleep. Common causes of sleep disorders can be bereavement, depression and anxiety, of course, dementia, sleep hygiene issues, and these are generally discounted, but they can have a significant impact on the patient. And spending long periods of time in bed, having an irregular sleep schedule, trying to force sleep, so all the things that when you follow a sleep hygiene program you're not supposed to do, right? You learn not to do. You learn to stay in bed only for sleep, use the bed only for sleep, try to develop a regular schedule, do not try to force sleep. Also afavoiding caffeine near bedtime. Some people are so sensitive to caffeine that they should really avoid it from early afternoon on. Smoking, nicotine intake, or other form of nicotine intake. Some patients, older patients I found, they drink green tea. They think it's healthier. They heard that it's healthier, and they're not aware of how much caffeine drinking several cups of this tea green tea can do. So they have this kind of regular intake of low doses of caffeine throughout the afternoon, and then of course they have difficulties. Medications such as corticosteroids and thyroid medication can of course interfere with good sleep. And sleep apnea is one of the most common causes of sleep difficulties and sleep disorders in older patients. Sleep apnea is characterized by apneas and hypopneas during sleep. And the term sleep apnea, when we say, well, the patient has sleep apnea, this is a term that collectively is used to describe both obstructive sleep apnea, OSA, right, where the apnea is due to the repetitive collapse of the upper airway, and also the central sleep apnea, CSA, where the apneas do occur, apneas and hypopneas, but they occur in the absence of upper airway collapse. Now, certainly sleep apnea is a risk for mortality in some studies. Untreated severe sleep apnea, although it hasn't been associated with an increase in mortality, in some other studies was associated with an increased association with an increased risk, of mortality. So from all causes. But certainly it has been recognized as has been associated with a risk for ischemic stroke in older adults. And I'm talking about severe, untreated severe sleep apnea. So increased risk of stroke, of cognitive abnormalities, hypertension, coronary artery disease, and even heart failure. So it's very important not to discount any complaint of sleep disorder. Patients may present saying, well, I need, I want the medication to stay asleep. Sometimes they've been treated by providers who've been prescribing benzodiazepines for a long time inappropriately, or low-dose antipsychotic, low-dose neuroleptic. But it's important that we investigate thoroughly the source, the cause of sleep apnea as a possible cause of sleep disorders. The treatment, as you know, the first line is behavioral therapy, sleep hygiene really, stimulus control, relaxation, cognitive therapy, sleep restriction therapy as part of a behavioral program. However, there are some medications that have been approved. And medications that have been approved for sleep disorders are benzodiazepines, non-benzodiazepines, and melatonin agonists. And then we have some antidepressants, that we already have described, trazodone and mirtazapine, antipsychotics not approved for sleep, not recommended for long-term use, as we know. And then we have over-the-counter agents that are commonly used by patients, valerian, melatonin, and I put alcohol here because it's used almost like an over-the-counter medication by some patients because they feel relaxed, but then they don't think that actually alcohol increases anxiety and arousal at 3 in the morning when they wake up and they're shaky. And some patients are very sensitive to alcohol, so they even a glass for some patients is too much. A glass with dinner, especially if dinner is 7, 8 o'clock, there's not enough time for older patients to. It's very too close to bedtime. So this is an issue. I would say overall, as we know, benzodiazepines should not be used for sleep disorders. Unfortunately, we see a lot of older adults still using them every night because somebody prescribed these medications for them. Non-benzodiazepines are not without risks, especially think about zolpidem and zolpidem extended release. Actually, if a patient is delirious, zolpidem can add to the confusion. It's associated with hospitalizations, associated with falls, so it's a problematic drug in many ways. But benzodiazepines in general certainly may be safer, especially for patients with respiratory issues, for example, COPD, non-benzodiazepine. We don't have tons of data, but some limited data suggests that they may be safer than benzodiazepines. And they do not predispose patients to tolerance with long-term use, for example, 6 months. Even though many patients on zolpidem would tell you different, so it's differently. So it's important to treat them kind of and prescribe them. We're not prescribing these medications because these are not part of the psychotropics that psychologists, even those with prescription privileges, can prescribe. But you certainly work with patients and you can suggest safer alternatives if it's possible, such as a low-dose trazodone, for example, unless there are contraindications, or low-dose mirtazapine. Risk of adverse effects in non-benzodiazepines should always be carefully selected and monitored. So it's important to take this into account. Now, ramelteon is it's a melatonin agonist, and is a medication that is indicated for sleep onset insomnia and has sleep phase dysregulation. It is not habit-forming. It does not appear to have the side effects associated with other hypnotics. But it does have important drug-to-drug interactions, especially in patients who are seriously ill, patients receiving palliative care, who may be on a number of different agents to treat symptoms. But certainly it is more well-tolerated, not really habit-forming. It doesn't appear, data suggests that there isn't really, it's not associated with a withdrawal syndrome if discontinued. We know about antidepressant that can be a longer that can be appropriate for longer use and relatively probably safer. Now, melatonin, I want to talk for a moment about over-the-counter over-the-counter agents such as valerian melatonin. Melatonin, as you know, is a neurohormone secreted by the pineal gland, and it can assist in maintaining sleep-wake cycle. However, again, it's a supplement. It's one of those supplements that's not regulated, so you don't necessarily know if there's contamination. Patients take between 0.3 milligrams to 20 milligrams, but it is relatively well tolerated without significant adverse effects, even though I've had patients who tried it and they became delirious, so they felt that they were having what they described a bad trip and anxiety. So for some patients, it absolutely doesn't work. And valerian can increase confusion in some patients. Very common in Europe. One recommendation would be to perhaps discourage patients, if they want to try melatonin, to try melatonin as a single agent. Sometimes they may go to Costco and find, or to the pharmacy. I love Costco, so I'm not saying anything against Costco, but I'm saying that they see so many supplements available, and where you have melatonin, GABA, valerian, and other supplements and other agents, herbal and otherwise. So if they have a bad reaction, it's hard to know which one caused the problem. So if they want to try melatonin, it's probably better to use it as a single agent. I want to talk to you for a moment about suvorexant, which is an orexin receptor antagonist. And this is a medication that was approved in 2014 by the FDA, suvorexant, for sleep disorders. Interestingly, the studies did not focus on older patients, but they included older patients, which is sometimes the best that we can hope for. So even a recent review, meta-analysis, has shown that it's relatively safe and effective based on the principle, basing on orexin A and B that are hypothalamic neuropeptides related to promoting wakefulness and regulating sleep cycle. So even though they have side effects like all of these agents, such as somnolence, possible rebound insomnia with discontinuation, they have been shown to be relatively safe and effective in older patients. So the choice of an agent really depends on the type of difficulty that the patient is having. And again, now focusing for a moment only on the use of non-benzodiazepines. For example, for sleep onset insomnia, a short-acting agent is more appropriate, Zaleplon, Zolpidem, even though it's very problematic in older patients. So it's not many providers' first choice. If sleep maintenance is an issue, probably a longer-acting agent is appropriate, but there's a problem with the elevated toxicity and the patient being drowsy and hangover the next morning. So Zolpidem extended release has been associated. Still chosen, still prescribed, but very problematic, even the not recommended, not one of the most recommended medications in older adults. If the patient is experiencing middle of the night awakenings, or some they have used Zaleplon and Zolpidem, some sublingual. The problem is that you need at least 4 hours in bed after administration. Otherwise, there is increased sedation. And I think, in my experience, that actually working with patients, there's more. If 4 hours not nearly is enough. As you know, older patients have decreased clearance, and they generally slow metabolizers, so 4 hours may not be enough, and they may wake up after 4 hours feeling very drowsy. So the adverse effects are really significant. So they have to be chosen with great caution. And again, if we are trying to address something long-term, antidepressants are probably a better choice. And I want to just conclude talking about delirium, which is one of the most frequent complications, frequent and undiagnosed complications that we see in primary care, also post-op, after treatment, in both hospitalized and non-hospitalized patients. It is, however, preventable by monitoring the patient, both medically, making sure that they're always well-oriented, especially patients at the hospital, maintaining using non-pharmacological approaches. So maintaining a well-lit room, reorienting and reassuring the patient, making sure that there is a board, there is a clock, that there is a calendar. You know, all of these, those of you working in the medical setting, these are very important components of preventing and managing delirium non-pharmacologically. Usually it is multifactorial, so it really depends. It could be triggered by medication. It could be a UTI that was undiagnosed and the patient becomes delirious. When we talk about delirium, there is hyperactive and hypoactive delirium. Hyperactive is easier to detect because you'll see agitation, you see a lot of anxiety. Hypoactive can sometimes be confused with depression because the patient becomes withdrawn and less talkative. However, there's a level of consciousness is altered and they are not oriented, which generally doesn't happen in depression. So hypoactive delirium should be managed or should be monitored because it can trigger hyperactive and it can be distressing for patients. It's important to, when we review the patient's medications, to understand that there are several drugs that are associated with delirium. Among the medical causes, delirium is prevalent in neoplastic disease, cardiovascular disease, stroke, Parkinson's, end-stage renal disease, and in the primary care setting, actually it's quite, well, the last point is not a cause of delirium, of course, but it is seen in 1 to 4% of patients in the primary care setting. Several medical causes and medications, of course. Fluid and electrolyte disturbances can be a cause. Yeah, I've seen this in primary care. There are patients who have chronic constipation, older patients, and some of them take laxatives every night. And long-term use of laxatives is not just a problem because it creates habituation and dependence, but also because it can cause fluid and electrolyte imbalance. Infections, drugs or alcohol toxicity, withdrawal from alcohol and benzos and SSRIs, metabolic disorders, low perfusion states, and postoperative states. Sedatives and hypnotics are associated with delirium, the risk of delirium, narcotics, anticholinergic drugs, incontinence, cardiac, GI, pulmonary, antidepressants, and also herbal preparations such as valerian and St. John's wort. The first line of pharmacological treatment is neuroleptics, with antipsychotics. So conventional is often used, haloperidol, Haldol is often used, but also atypical antipsychotics have been used. Olanzapine in some hospital settings, olanzapine frequently used, risperidone. But neuroleptics are still, many studies have come out questioning the efficacy of neuroleptics versus placebo in different hospital settings, and certainly that is something to consider. But the reality is that the first line of pharmacological treatment of delirium is still a neuroleptic. one important role that we can have, that psychologists can have, is first of all detecting delirium, making sure that we don't, that if the patient appears sedated, kind of confused, quiet, that we don't think just the patient is depressed. The patient may be delirious. And also providing non-pharmacological approaches, education, making sure that everything else is addressed, is taken care of, and working with the medical team, reassuring the patient and also caregivers. And I just wanted to end by mentioning briefly a case example. It's been a long lecture and it's been a lot of information, and I hope that at least most of it was pretty straightforward and perhaps added something to your tool bag. So this interesting patient, a 96-year-old man with coronary artery disease, diastolic heart failure, hypertension, primary cardiomyopathy, hypothyroidism, and basal cell carcinoma of the face as part of his medical history, and he was on 14 medications. So talk about polypharmacy. And after a careful review, it was obvious that, excuse me, that these medications were necessary to manage the different conditions he had. So it was quite a good balance. He had been functioning relatively well. However, he presented depressed with somatic symptoms of fatigue. He stopped eating. His appetite had decreased. His main complaint, actually, when he came, when he presented, was, I want to write my biography. I'm 96 years old. I've really seen a lot. I really want to leave a legacy to my family and friends. I feel that it's my responsibility to put this down, but I'm overwhelmed by all the stories. I don't know which one I should approach first. I have so much paperwork, so many boxes full of journals and articles and diary and documents. And how do I continue? How do I carry out this project? This is so important to me. At the idea that he may not be able to complete it before dying, he was absolutely very upset, very sad, almost as if his life had no meaning unless he was able to capture it and complete this project of writing his biography. And the biography that was supposed to include a lot of kind of lessons, what he had learned, working also. He was involved in government and politics, and so he really wanted to transmit some of these lessons. So there were somatic symptoms of depression. There was existential suffering related to meaning and purpose, and feeling that this meaning and purpose was threatened by his difficulty managing this enormous task. There was cognitive and emotional overwhelm, but he had good insight. And so, this would be a case, of course, for discussion, but in spite, I think the point is, in spite of the 14 medications, it was important to recognize that the somatic symptoms, like the decreased, he wasn't eating well. He really had very poor appetite. And in his past, so mirtazapine came up as a possibility, but in his past he had what he described as a bad reaction. Somebody had prescribed it to him. Probably they started at a dose that was too high. He didn't like the sedation, but he felt really upset, and he was not willing to even consider it. And so we started sertraline 25 milligrams, titrated to 50, which was well tolerated, was enough for him to create a kind of a buffer that allowed us to engage in problem solving and really looking at these issues of grief and loss and legacy, and strategize and find a plan that would allow him to complete some elements of that of the project, and also delegate to others who would continue. He hooked up with a local newspaper editor and made sure that if he should die before completing the project, somebody would have continued on. So there were several components to the treatment, but adding 1 hour medication with careful monitoring was the appropriate thing to do, because again, he was losing weight. There was agitation, didn't sleep well, but mostly was losing weight. There was fatigue and irritation, and so I had some concerns about impulsive behavior and possible suicidality because of this overarching lack of sense of meaning, and nothing makes any sense, and the anger. So I was concerned about that. And the pharmacological approach turned out to be a reasonable and acceptable and appropriate choice, and his symptoms improved also as part of a plan, as I mentioned. So I just want to, well, I can do the second case briefly, but this is a 67-year-old woman with osteoarthritis, so significant pain, major depression, hypertension, GERD, and chronic anxiety, who worried all the time about her pain, about the pain on being treated, about not receiving adequate treatment, the hypertension, GERD, that she couldn't eat the foods that she really liked. So there was this chronic anxiety, which was really presented as a GAD. So there was a significant component of psychotherapeutic work, developing strategies to manage symptoms of exacerbations, managing pain, improving communication with providers, but also the only pharmacological intervention was mirtazapine 7.5 milligrams at bedtime, and it was never increased. This was enough to calm the anxiety, to calm the rumination, a little bit of sedation the first week, but we worked with her home health aide who was there 24 hours and making sure that the patient was safe. So this was well tolerated, and it didn't need to be titrated. We certainly didn't want to add to the symptom burden, and it turned out to be like a small but very significant intervention in her life. So in summary, what can I say? We need to be very careful when we work with older patients, very cautious, taking into account all the risk factors, the personal situation of the patient, their goals, what they're dealing with mentally, psychologically, spiritually. But most importantly, when we prescribe, we need to reassess at each medication and dose change, very close follow-up, keep checking in, and allow the patients to encourage the patient to endure, to talk about any side effects or any undesired effects, any barriers, any concerns. Obtaining collateral information is very important. Sometimes it's not possible. Minimize polypharmacy if it makes sense and if it's possible, but we certainly don't want to destabilize balance in someone who's been doing well on a medical regimen, unless the medical regimen doesn't make sense, of course. Let's work with our patients and through the side effects, and we also need to be familiar with available resources, referrals, in the medicine, as in psychology. It's very important to know what we know, but most importantly, we need to know what we do not know, and how we can get that knowledge. How can we develop that knowledge using resources, colleagues, and really understanding that after all, we're working with a vulnerable population, and we want to give them the attention and recognize that they can be involved in their in the treatment plan. And I'll leave you with this quote from this French psychologist that really speaks to how older patients are so rich, and there's so much development and growth that can be accomplished at any stage in life, at any moment, up to the moment of, just before death. And so we want to really honor that when we work with this population. So thank you so much. Tomorrow I will talk about psychopharmacology with the patients with chronic pain. And again, we'll try to keep it as practical as possible. And just to a final note on the exam, just repeating, the exam will be pretty straightforward, so you'll do absolutely fine. I promise you'll do fine just by listening to the lecture and looking at the slides, reviewing the content of the slides, and you will receive a study guide that will really highlight this in great detail. So I wish you all the best, and thank you. Take care. Bye-bye.